things like a jukebox and photographs with sepia tone loving. Love is the answer, at least, for most of the questions in my heart. Why are we here and where do we go, and how come it's so hard? Not always easy, and sometimes life can be deceiving. I'll tell you one thing, it's always better when we're together. It's always better when we're together. Yeah, we'll look at them stars and we're together. Well, it's always better when we're together. Yeah, it's always better when we're together. And all of these moments just might find their way into my dreams tonight. But I know that they'll be gone when the morning light sings or brings new things. But tomorrow night you see that they'll be gone too. Too many things I have to do. But if all of these dreams might find their way into my day-to-day scene, I'd be under the impression I was somewhere in between, with only two, just me and you. Not so many things we got to do, but places we got to be. We'll sit beneath the mango tree now. Yeah, it's always better when we're together. We're somewhere in between together. Well, it's always better when we're together. Yeah, it's always better when we're together. I believe in memories, they look so pretty when I sleep, day now and when I wake up, you look so pretty, sleeping next to me. But there is not enough time, and there is no song I could sing, and there is no combination of words I could say, but I will still tell you one thing, we're better together.
I'm on my way, I'm making it. I've got to make it show, yeah. So much larger than life. I'm gonna watch it growing.
You can feel it. You can feel it. Mics are on, definitely. It's like this, like the official publicity picture that the university has. It was taken 7 years ago. Mine, 7 years. Right when I first started, like, so the university has a photographer, and we all have to like wear the white coat and go over there and get it. I was just looking at the, the elevators, there's mirrors all the way around. I didn't realize how bald the back of my head is until I actually looked at it. There it dips.
Hi, good morning. Thank you, everyone, for getting here so early, starting off the Western Vascular Surgery meeting. We had a great session yesterday, and I'm sure we'll have one today. So just be relaxed and enjoy the content. I think it will be stimulating, invigorating, and we'll all probably learn something as well. We're going to start off this morning with our newly formed DEI committee. We formed this committee about 2 years ago under the leadership of Ben Starnes. when he was the president of our society. And they've worked really hard in a number of areas to move our society forward. And today they have a wonderful segment put together, Equal Pay for Equal Work. And we have Dr. Yi that's coming in all the way from, actually, where are you, Dr. Yi? Colorado, thank you, to talk to us about equal pay for equal work. I'd like to thank our committee, Dr. Chavez, Dr. Ziegler, Dr. Kabutey, and our sponsorship from Cook as well for this morning breakfast session. And so just go ahead and enjoy. Thank you.
Thank you, Dr. Rowe. I'm Laura Marks. I'm with Cook Medical. Just a really quick this morning, as Dr. Rowe said, thank you for getting up early, kicking off Western Vascular meeting. I love this meeting. I think I said that last year for the first DEI luncheon that we got to sponsor. This is a great opportunity, and we're very grateful for the efforts, the support of DEI with this society. Cook, we remain rooted to our values as a family-owned company, and treating everyone with respect is important to us. And I believe it's also important to you. We recognize that the strength in a diverse workforce and diverse culture and an inclusive culture is essential to our future, and that applies to this group as well. And again, thank you very much for coming. Looking very forward to hearing Dr. Yi and Dr. Ziegler, Dr. Kabutey, and Dr. Chavez speak. So with that, I will give you your DEI chair for this year, Dr. LeAnn Chavez.
Good morning, everyone. Thank you so much for being here today. Thank you, Laura and Cook Medical, for the continued support for our DEI efforts. Move this away a little bit. So welcome to the opening breakfast symposium. So equal pay for equal work is our topic. The agenda this morning will give a little bit of overview, a little bit of deliverables and actionable items that you could consider when you return back to your home institution. And the major session will be Dr. Yi's talk with the discussion of her work, her peer-reviewed article, publication of Equal Pay for Equal Work, Disparities in Compensation in Vascular Surgery. So first, I'll have to like to provide a land acknowledgement. The DEI Committee wishes to acknowledge and thank the Lekwandi people, also known as the Sungis and Esquimalt First Nations communities, and the Wasanic peoples whose historical relationship with the land continue to this day. The DEI Committee was started in 2021 as stated by Dr. Rowe. Our mission statement as stated is to promote an academically enriching and supportive climate that allows all members of the society to thrive and succeed. And looking at the landscape of DEI within the last few years, you can see that there's a brief overview of the DEI work underway, and it's increasingly growing. Over the past 3 years, DEI initiatives and overall DEI landscape in vascular surgery is evolving across the country. Regional and national societies within vascular surgery continue to establish formal DEI committees and our initiatives. The growing establishment of DEI in vascular surgery is present for numerous reasons. The talk will focus on the change of who is deciding to become a vascular surgeon and how that's continued to evolve over the years. This graph is demonstrated from the American Board of Surgery, demonstrates the diplomats by year from 1983 through 2021. In 2021, 75% of newly board certified vascular surgeons were men and 25% were women. In 2021, Dr. Chelsea Dorsey and colleagues described the status of workforce diversity with respect to sex and race, ethnicity, using general surgery and orthopedic fields as reference. Dr. Dorsey looked at data up to 2017 on vascular surgery integrated programs and 2 different time periods for vascular surgery fellowship to compare historic to more contemporary data. As you can see from the second row, proportions of trainees within vascular surgery fellowship, looking at the timeline and comparisons of 99, 2005 versus 2013 and 2017. There's a growing number of women, Hispanic, and Black applicants within trainees of those fields. Looking forward with DEI, the first year where DEI Summit was held by our president and sponsor, Dr. Rowe, to provide a forum of all vascular society DEI centers and committees to meet. The collaborative effort to learn from each other was an invaluable resource as each DEI committee continues to navigate their standing among each society. What can we do now? Consider participation in ACGME Equity Matters self-paced education experience. The modules address issues related to diversity, equity, and inclusion, with initiation of DEI topics in vascular surgery started with consideration of healthcare disparities among our patient population and outcome data. While this remains a valid topic for our specialty, I would like to urge you to take a step further into DEI education. Simply increasing the diversity of surgeons in our field is not sufficient, but rather we need to practice cultural competency skills to learn and care for our patients better and support our future colleagues. With this, I'd like to highlight a new addition to the Western Vascular Society, which is a DEI grant. It's a generous offering and donation by our sponsors. The DEI Committee is happy to announce the Western Vascular Society DEI grant is open for applicants. Please scan the QR code for the opportunity to receive an award of career development, our DEI-focused research project. As stated, the grant would be about $10,000 for an active member within the Western Vascular Society, and we appreciate your support and application to the following. Next, I'd like to bring up Dr. Yi, who I say is an assistant professor at Colorado. She also is highly involved in quality metrics and evaluation of healthcare policies and safety.
Good morning. Thanks for the opportunity today to talk. Thanks to the Western Vascular Society and the DEI Committee for inviting me. And yeah, I'm JenniAnn Yi. I'm from the University of Colorado. And like Dr. Chavez said, I'm going to discuss one of the papers we wrote for JVS talking about equal pay for equal work. And I have no disclosures. So objectives today are really to first acknowledge that the pay gap exists, as well as understanding the different factors that go into creating and then perpetuating the pay gap, not just race, ethnicity, and gender, but also other factors about our practice overall and how this then can be addressed to continue to work towards changing this fact about our society in general and eliminating pay inequities. So what is pay gap? Pay gap is usually represented as either a ratio or percent difference in pay between two groups. And for gender pay gap specifically, this represents the female to male ratio of median or average annual earnings among full-time workers. And in 2021, this pay gap across the US workforce was 83%, where the average woman made only 83 cents for every dollar earned by men. And you can see here that unfortunately the pay gap only increases with increasing education. And so women who have advanced degrees are actually likely to have a greater salary discrepancy when compared to men with similarly advanced education. This then also creates an increasing pay gap over a lifetime of work. And so women not only will start their salaries at a lower income, but they also have a lower overall earning potential throughout their career trajectory. So at increasing ages, the salary gap also increases, making older women in particular at risk financially when considering retirement based on their lost earning income potentials throughout their overall careers. Medicine is one of the highest paying occupations, but it also is one of the fields with the greatest pay gaps. And this graph shows basically a simulated lifetime earning potential of a man versus a woman currently in the US. And as you move towards the right, you can see that in higher paying fields, this pay gap increases. So a slightly smaller pay gap or difference in the primary care field. And as you move towards the right, again, these are now specialties and specifically surgical specialties where the pay gap is the highest. And in 2019, a Doximity report specifically looked at all reported physician salaries across the US. This is one of the largest studies that has been done regarding physician salary overall. And vascular surgery is unfortunately one of the biggest offenders. While we were one of the top 5 earning specialties within medicine, we also had one of the highest pay gaps by gender, which was approximately 20%. And this is despite the fact, as Dr. Chavez already pointed out, that vascular surgery is actually one of the fields with the highest representation of women overall, with about 15% of current board certified vascular surgeons being women and over a third of current trainees. This income difference also is differentiated by race and ethnicity. And you can see here that for Black and Hispanic physicians in particular, there's a dual or additive effect of race and ethnicity with gender on their overall income potential, making these populations in particular more disadvantaged. So what sort of factors impact pay? I think a lot of us are familiar with this when we think about jobs in general. And some of the big things that we look to are specialty choice, practice characteristics, overall ability to be promoted, and our productivity in our roles. And these same factors should then be considered when we're trying to understand what causes pay inequities. And so beginning with specialty choice, you can see that women overall tend to make a higher proportion of specialty physicians in lower paying specialties. So at the top here, we see pediatrics, which has one of the lowest annual salaries in medicine. About 60% of all practicing pediatricians are women. Whereas on the higher end of the spectrum, for specialties like orthopedics, urology, and plastic surgery, only about 10 to 15% of those specialties include women. And some of the considerations why women may be choosing to go into these lower income specialties are things like prioritization of flexibility in their jobs, better work hours, more control over their schedules, and better practice environments, which are valued despite the overall decreased earning potential. These are also some characteristics that then can factor in when thinking about practice type and practice location and how that impacts pay. One of the first decisions that we make once we're done with training is what kind of practice we will join. And even looking in private practice, the employment model itself creates a differential in the gender pay gap, where solo practitioners experience about a 15% difference in pay. And in group practice, they see about a 20% difference in pay, whereas as an employee of a healthcare system, this goes up even further to 22.6% difference in pay. Another big consideration is academic versus private practice. And an early career vascular surgeon will make, on average, $54,500 less in choosing to do academics over private practice. And within this, women are far more likely to choose to go into academics rather than private practice. So why do women choose to go into these lower paying academic positions? One major factor that continues to come up is the impact of family on career. And women are far more likely to adjust their careers based on families, which was also demonstrated in this study, again, of the overall US workforce by the Pew Research Center, which found that women, or specifically mothers, were more likely to make major career decisions like turning down promotions and decreasing work hours after having children. Thus, the draw of an academic position for women may be more so related to values outside of monetary compensation, like having formal maternity leave policies in place, which are far more common in an academic role. And unfortunately, during the COVID-19 pandemic, we only saw increases in these same factors that contributed to the gender pay gap. During the pandemic, we saw more women stepping away from their work to care for their families, which then resulted in less women overall in our workforce. And then as women came back to work after the pandemic eased up, they came back in lower paying positions with also a decreased salary than before as somewhat of a penalization for this period of unemployment. And again, we see that this impact is only increased for particularly women of color. Now, geographic location is also one of the factors that can change how much of a pay gap we see between men and women. And this is a US Census Bureau map demonstrating regionally how the gender pay gap varies between states. So you can see that clearly there are some states that have a greater pay gap than others. And this could factor in theoretically into where people choose to practice in order to mitigate some of those issues. However, independent of this regionality, a Doximity study, the same one in 2019, found that across all metropolitan statistical areas, it really did not matter, and a male physician would still out earn a woman physician on average $1.25 to every dollar earned by women. So looking further, promotion is also something that we consider in trying to increase our salaries throughout our careers. So how do we compare when looking at this factor? One study examining specifically gender disparities among academic vascular surgeons found that in general, male vascular surgeons were more likely to hold important leadership positions, such as being chief of their division or chair of the Department of Surgery, as well as to be in a higher academic rank of professor, whereas women vascular surgeons were more likely to be in a junior academic position of assistant professor. One thing that the same study found was that men were more likely to have higher number of publications, in addition to a greater number of citations and an overall higher H index than women, which was considered to be a potential explanation for this differential in leadership positions and rank. However, when the authors further adjusted by years in practice, you can see that actually per year, women had a higher H index than men. And also women overall were more likely to receive NIH funding, which are both very important metrics, of course, when we consider academic promotion, and thus directly counters to some degree this argument. And this significant underrepresentation is only replicated basically when looking at racial and ethnic minorities across academic leadership as well. So among US academic institutions, white physicians accounted for 85% of professors, 88% of chairs, and 91% of deans across the US. In contrast, Asian physicians represented 6% of professors, Hispanic physicians represented just under 3% of professors, and Black physicians represented only 1.25% of professors. And the authors further noted that at this current promotional rate observed over the study period of 12 years, it would take nearly 1,000 years for the proportion of Black physicians to accurately reflect their proportion of the US general population. So last, looking at, I think, one of the big metrics that affects you no matter what position you're in, productivity. This was a study in JAMA surgery that compared specifically patient referral patterns for male versus female surgeons. And they found that while male surgeons accounted for a little over 75% of the surgeon population, they received a greater, they received a greater proportion of referrals from both male and female physicians, and that overall women were less likely to receive procedural referrals than their counterpart male surgeons. This was a New England Journal of Medicine study looking at specifically primary care, and they found that while female physicians, specifically PCPs, were about 10% less productive overall in their office visits when looking retrospectively in their charging data, women were also, upon surveying them, were more likely to spend greater time, about 15% more time with each patient, thus representing a value of patient care that is not always accounted for when considering productivity and pay. And finally, for specifically vascular surgeons, this study looked at industry and how that affects salary and payment overall for vascular, academic vascular surgeons. And not only were men more likely to receive industry payments, where they were about 82% of all industry payments, they also had a significantly higher amount paid per year than women. So altogether, when we look at this, I think one of the greatest myths about gender pay gap overall is that it can somehow be explained by these factors that we're discussing. But finally, this study, which looked at US physician salary across all medical schools, they found that despite adjusting for those factors like age, experience, rank, payments, productivity, that women's salaries still skewed significantly to the left or the lower side of the income spectrum. And these adjustments actually only accounted for about 40% of the unadjusted pay gap. So clearly there is still something that we cannot quantify by those factors that contribute to pay gap and represents ongoing systemic issues that we need to address to achieve pay parity overall. And one example of how pervasive, I think, and also insidious gender discrimination and devaluation can be is this study, which compared directly urologic and gynecologic operations by CPT codes, where the investigators found matched male to female anatomic operations. And by CPT, across the board for markers of productivity such as total work RVUs, total RVUs, work RVUs, and reimbursement or fees, male procedures were still valued higher than female procedures. So these changes are clearly, these factors are clearly ingrained in our society. And for perspective overall, 1963 was when the Equal Pay Act went into place in the US. And the current, at the time, the pay gap was about 59 cents for women to $1 for men. And, now it's 2022 and our most recent data is about 82 to 83 cents. So that's over 60 years of change. And in the last 20 years, there's been less than 10 cents of an increase in the gender pay gap overall for US women. And this is, again, a projected graph going off of the known changes in pay gap and the known increases broken out by race for women. And Black women can expect pay equity in 2369, and Hispanic women can expect pay equity in 2451. So these rates of improvement are slow and are frankly unacceptable, which is why it is so important that we examine these issues closely and take measures to actively change these statistics. And finally, I just wanted to state that, I'm very happy again to be here for this opportunity, and I'm so glad that we're working towards equity overall with our DEI committee, and that, unlike equality, equity addresses a lot of these societal issues that lead us to different positions when we are at the starting line, and that the goal overall is truly justice, where these systemic barriers are taken down and we no longer have to account for these by variation in support. And that was all. Thank you very much for the opportunity.
Ready? Yep. Next, we'll have Kenneth Ziegler come up and give us more discussion strategies for narrowing the wage gap. Oh, no, that's Dr. Kabutey. May we have the next talk, please, which is Dr. Ziegler. I think that the information that you provided, Dr. Yi, was very helpful and inspiring, and hopefully can spawn some more further discussion among the audience. So now we'll go on to Dr. Ziegler, racial pay disparities in medicine.
Thank you. I'm going to attempt the impossible right now and give you a 5-minute overview, an extremely complex thing. But the thing is, you already know this, and I'm going to show you in the slides that you already know this data, right? Now, first thing, I'm following a great lecture about the gendered pay gap. But one of the things I want to put in the wide view of things, because I'm going to focus on the race part of this, is that there are significant disparities at all levels, considering any minoritized identity as variables, whether it's gender, whether it's a race, whether it's identity, any other form of identities, LGBT representation. But these are not independent variables. All right, we have this idea of intersectionality, which we really haven't discussed in this group before, that all of these are related to each other, right? And we as much as we want to try to separate it out as scientists and put them apart, they have to be discussed within the context of each other, because you don't know exactly why something is happening, whether it's because one part of your identity or another, okay? And ultimately, when we're working towards justice, advocacy, change, and fairness, these are not zero-sum games, right? We all rise together. So in 2018, Medscape had its very large physician survey out there. Came up with about 43 slides worth of data, but these are the important ones that we talk. If you look at all positions across the board and break them down by their racial identity, you can see that there is a definite difference in their average salary. Now the breakdown demographics are listed on the right for age and gender. You can see it's fairly well represented, and then there's 34% of women being in the population, about what we can say is about what we would expect for a fair representation of all physicians. Now, as we were talking about, there's these various factors that we talk about that say, okay, well, maybe it's this, maybe it's that, maybe it's that, right? But if you want to talk about specialization choice, you'll see that there's a difference on who specializes and who goes into primary care. This is different between the groups. And we know that primary care specialties pay less, right? But that in and of itself doesn't explain things, because if you look at primary care physicians, you see that in each group, women actually make less than everybody else too, in addition to the whole racial factor. Again, intersectionality, we see two of these contribute things that may actually be synergistic in a bad way. Now, you know this. Everybody already knows this. And you can look at this slide and it tells you why. No one's happy with how much they're getting paid, right? But you can see that the people who are affected the most are even less happy than people at the top. And it's not just us. It's all the way throughout the system, right? I'm not gonna try to go through every single one of these slides for you, all right? I just don't have that time, but this is the level of detail we can look at, going from physicians, APRNs, PAs, through every level of the system, nursing, therapists, down to the people who are out in the community doing the community-based work. And you would see there is a difference. Non-Hispanic representation, non-Hispanic identifying people consistently made more than Hispanic people as nurses, as aides, technicians, communities. But you'll see that Asian Americans actually consistently made more than Blacks, Native American Indians, and multiracial individuals across all occupations, except at the very top, higher levels of income, physicians, advanced practitioners, and therapists. However, when compared to white physicians, they only made more than white physicians in advanced practice, registered nurses, LPNs, and aides. That's one study. The AAMC has now gotten into this in 2021 to look at faculty salaries across the academic spectrum. This report is available to you freely on their website. It's a $0 download. I have a copy of it if you want it to. It's actually 90 pages long. So I'm going to give you the brief summary on this slide here. This is the most important thing. As much as we talk about race, it's actually gender that was the primary factor driving compensation inequality. Men across the board, across all groups, consistently made more than women of the same race and ethnicity. As far as race goes, even in departments and specialties with the most representation of faculties of color, like OB-GYN, gaps in compensation by gender and ethnicity still existed. So the mere presence doesn't correct for anything. So again, 5-minute gap thing, conclusions. We are having advanced research at high levels being conducted, right? And this involves going through and trying to analyze all these multiple variables within each other and amongst each other. Again, it's where this whole idea of intersectionality comes through. And you'll see a lot of the things are involved. It's our history, how we got here in the first place. It's our distribution of how by age, by rank, faculty rank, and increasing inclusivity as we go along. How all these is hopefully going to change, but you've seen it still looks kind of dismal if we're looking at 1,000 years towards equity, all right, or equality. Next steps are how we're going to use this data to affect our equitable change and how all of this affects future directions in DEI-based work. And at this time, I'll turn it over to Dr. Kabutey. So.
Can we advance? Is that Yeah, it is. I think All right, morning. Just to move things along and allow time for questions. Again, thank you all for showing up this morning. Thank you to our sponsors. I don't pretend to have any of the answers at all, but the questions are certainly worth thinking about. And this is coming from Mr. Arthur Clarke, famed novelist. We've kind of had this slide already, but 1960s, it was about 59 cents on the dollar for women compared to men. 2152 is where there's projected to have equity. What I found was quite interesting. It's not really that women are making more money. It's potentially that men are going to be making less money. It's more on the men's side comparatively. So it's interesting. We have still a very long way to go. In terms of vascular surgery, this is a VA study. We actually did okay. If you see here in the small print, they were saying at least in the VA, the disparity was about $68. Comparative to some of these other specialties, cardiothoracic and neurosurgery, was quite a large wage gap. Pay disparity begins early, and it begins with our residents and medical students. Again, I'm going to kind of rush through this to give ourselves some questions, but this was an anonymous study, Dr. DiVirgilio, 607 categorical general surgery residents, 70% completion rate. Men and women had anticipated same working hours. They anticipated retiring at the same time. They had similar interests in holding leadership positions, having academic careers, and pursuing research. There's really no overall career differences or expectations for men and females. However, females did think they were going to make lower salaries, and females viewed salary negotiation less favorably. Females had lower minimum salary expectations. They had lower ideal starting salary expectations, and females found negotiating much less appealing, and they were less likely to pursue other job offers to try to boost their salaries. So, I'm going to go over some maybe potential ways we can try to decrease this wage gap. Encourage departmental and institutional policies that promote transparency in defining the criteria for initial and subsequent salaries. Transparency. That's one of the things that is the main goal and thought that to help reduce the wage gap. This is actually a study coming out of UCI. The aim of the study was to evaluate differences in compensation between genders within a large academic healthcare system with a transparent and publicly accessible salary. You can find anybody's salary at UCI within the University of California healthcare system online. This one looked at 170 surgeons, 8 specialties, 29% of the people applicants were females. Despite this, and with our large transparent system, still a massive difference in salaries, even with transparency. So what I'm saying is it's not that easy. Even just having a transparent system, there's still large wage gap differences. So a few other criteria, and I don't think I'll go through all of them. Establish programs to empower women to understand their worth and negotiate appropriately. These should be extended to residents and medical students so the essential negotiation skills are fostered early in training. Provide implicit bias training for department chairs, deans, search committees, and private practice employers. This will increase awareness of how subtle differences in the evaluation of male and female physicians can impede compensation and career advancement. Again, we probably all go through these courses. We probably all have to go online and have our GMEs have us do these courses, but it does probably make a difference. This was a study where it was just a 2.5-hour workshop to try to get gender bias habit changing interventions. And it seemed to work. At least at 3 months, they did see maintained abilities of department chairs, et cetera, to at least consider gender issues. All right, we're supposed to have about 15 minutes or so for questions. Sure, I want to make sure we leave enough time though, especially we have some experts on the panel here. So again, a few other things: ensure routine assessments of a department or practice gender equity and pay coupled with performance reviews for all surgeons to ensure fair compensation based on transparent and predetermined metrics. Encourage non-departmental oversight of compensation models, metrics, and actual total compensation for all employees with annual internal publication of summary data by rank, years, employment, and gender. Increase efforts to promote women into senior leadership positions and evaluate the organizational, cultural stuff to promote equal access to opportunities and resources, value work-life balance for both men and women, and create a supportive environment. So in conclusion, this is a major issue. Strategies for narrowing the gender gap will require multifaceted approach, departmental level, governmental level, societal level, really an individual level as well. Okay, thank you.
And thank you so much for joining us this morning. Anybody have any questions, please step up to the podium. Like to spawn any discussion you'd have regarding our topics discussed today. So equal pay for equal work. Yes.
Hi, good morning, everybody. Sorry, Wade, were you? Okay. Thanks for bringing this program and appreciate the DEI committee helping us continue to focus on these issues. Couple of thoughts. So when we talk about compensation discrepancies, there's a lot of variables, many of which have been discussed. Choice of career, how to pursue your interests. When we look at Caitlin Hick's paper on the top 1% of vascular surgical earners, they're almost exclusively men working in OBLs where they've started their own business and a high percentage of procedures like atherectomy. So, that's one variable that didn't really come up here in terms of exactly which type of career working environment you want to pursue. I wouldn't necessarily recommend that myself, but it is, an option depending on that. I'd also, the last presentation, Dr. Kabutey's presentation, I think unfortunately he had to kind of skip through a few things quickly, but I think the idea that it's not just transparency, as he mentioned in some of his slides, it's actually very specific granular compensation requirements. And so, for example, in our division, we have an 11-page compensation plan, which includes, among other things, a differential compensation for paper published with an impact factor of less than 3 to 10, or greater than 10. A number of classes taught, scores on student resident evaluations. I mean, to our greatest extent possible, trying to account for every aspect of contribution professionally. And the more granular the compensation plan becomes, the less likely it is that people are not compensated appropriately. I'd also point out that we have been subject to external audit, both within the division and the department and across the school, looking at compensation by faculty member, by rank, by gender, by ethnicity, et cetera. And that's a regular process for us. And as leaders, we get a report on that every year. And then I guess, my final comment is that it's frustrating to see presentations where, the problem is repeated, but the answers are uncertain. And it is useful to have these types of interactions to try to help us all understand where the opportunities lie. But I do think the narrative has to change from there's a problem to here's the solutions and here's how they worked in other places and here's a best practices model, how we should address some of those issues. And, I'd also just point out for the record, our university has the highest percentage of women department chairs of any in the nation. Over 40% of our department chairs are women, including some very high performing departments like our otolaryngology department this year is #1 in the nation in US News and World Report, and it's chaired by a woman. So I think, improvement is possible. The answers I think are there. There are best practices to kind of emulate. And I think the narrative, it would help all of us to shift the narrative a little bit to here's changes we've made. Here are the improvements that we've been able to document, and perhaps these are lessons that we can all draw to apply to a broader situation. So thanks for bringing this to this discussion to everybody's attention.
Yeah, thank you so much for those comments. I think very true. Actionable items are going to be the continuous mode for change. I think making transparency and having a detailed compensation that you've described is that you are ahead of the game, and hopefully will continue to emulate future aspects of how other departments and divisions may provide compensation models.
Oh, just one question. Sorry, Wade. Sorry. So who should lead that discussion? I mean, we have assistant associate professors, or who should lead that discussion, that narrative that you're talking about? Chair, the health system? Who?
So I'd like to thank the committee actually bring this thing, very unpopular topic, like front and center in our society, this discussion, and obviously there's lots of strong feelings about it. I kind of want to make just a point to Ron's last thing, why there's a disparity. If you look at, I was striking to see the presentation and the VA system where there's scaled system, there's no disparity in vascular surgery between women and men. But when you look at referral pattern, which I was striking to hear that women and men get an equal amount of referral, but men has more of a procedure-based referral. What do you think what's behind it? Was it the way we talk to referral physician? Was it how referral physician perceiving women surgeons? And do you have any insight on that?
Yeah. So thank you for that question, Dr. Zoe. One on that paper were specifically about referral patterns. They also sort of talked about maybe it's because, non-procedural referrals, it's more so about a discussion with the patient. Again, hearkening back to this question of maybe women physicians are more likely to take that time to have conversations with their patients. This is, of course, very subjective, what the authors concluded, but that perhaps that's preferred, whereas a procedural referral is more straightforward and there's less room for that need for discussion and more of this conversation. I don't think that that's necessarily proven, but that was one thing that came up in that paper. And then I also wanted to make a couple comments going back to the other great points from our audience members. I think Dr. Rowe is absolutely right that this change needs to happen. It can be bottom up, but also it must be top down as well. And so it needs to happen at all levels. To Dr. Dahlman's point about transparent compensation models, I think a lot of academic centers do value things like, age factor, how much you participate in education, how much you publish, those sorts of metrics, but it also varies how they factor into your compensation. So for instance, for some departments, this is it's a baseline so that you have to meet these academic requirements in order to qualify for a portion of your compensation, whereas potentially what you're describing, I'm not sure, is something where the more that you do academically, the more you get potentially compensation, almost like an incentive for academic practice outside of just clinical RVUs, which I think is great. But those are the sorts of things that I don't think we know about our different compensation models. And lastly, to the point of what can we do, I think that a lot of things are existent in terms of literature, but they exist in the corporate world. So things like pay equity audits and salary transparency, but there's also things that come up like disclosure of prior salary, which should not be a part of contract negotiations because you should just come into a position and be considered, equally for someone else who would be considered for that position. Intentional recruiting, intentional hiring, intentional interviewing for positions as well, and making that a clear expectation when you go into those sorts of efforts. And of course, something that's been discussed over and over, but we still don't seem to necessarily do the best job, which is fixing the leaky pipeline where it starts with mentorship and sponsorship. And that also would require promotion to these higher levels so that that can happen. And I just, again, thank you for those comments. I just wanted to hark back to all of those and address it.
Thank you. Well said. Any other comments? Well, we're almost about out of time. Thank you so much. Hopefully this continues to spawn some discussion offline and at our social events, and we'll see you back in the next session.
It's a good day for dreaming. It's a good day for dreaming.
the chord David played and it pleased the Lord. You don't really care for music, do you? It goes like this, the fourth, the fifth, the minor fall, the major lift, the baffled king composing, hallelujah, 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 hallelujah. Your faith was strong, but you needed proof. You saw her bathing on the roof. Beauty in the moonlight, oh yeah. She tied you to her kitchen chair. She broke your throne and cut your hair. And from your lips she drew, hallelujah. 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 Maybe I've been here before. I've seen this room and I've walked before. Used to live alone before I knew you. But I've seen your flag on the marble arch. Our love is not a victory march. It's a cold and it's a broken hallelujah. 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 Maybe there's a God above, but all I've ever learned from love, how to shoot somebody who outdrew you. It's not a cry that you hear at night. It's not someone who's seen the light. The cold and broken hallelujah. 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 it's running all its way. It's his day with hope and calm. And you fill my life with laughter. You can make it better. Ease my trouble, that's what you do. Cause the love is divine. And it's yours and it's mine like the sun. At the end of the day, we should give thanks and pray to the one. Say, have I told you lately that I love you? Have I told you there's no one to go? Fill my heart with gladness, take away my sadness. Ease my troubles, that's what you do. For the love that's mine, and yours and mine, and it shines like the sun. At the end of the day, we will give thanks and pray to the one. Have I told you lately that I love you? Have I told you there's no one above you? Fill my heart with gladness, take away my sadness. Ease my trouble, that's what you do. Take away my sadness, fill my life with gladness. Ease my trouble, that's what you do. Fill my life with gladness, take away my sadness. Ease my trouble, that's what you do. Keep on learning, soldier. Keep on falling. Keep on turning. Cause the world needs you more. Ours. Keep on lying. While your people keep on dying. Keep on turning. Cause the world needs you more. I'm so tired and let me try it again. But the last time I learned I left the whole world upset. I'm so glad that I know more than I knew then. Gonna keep on trying till I reach the highest ground. Teachers, keep on teaching. Preachers, keep on preaching. Keep on turning. Everybody me tomorrow.
Thank you, everyone. Let's move to start our session. And as we get started, York is our past president is going to give us some updates on Canada. He was our local program arrangement coordinator, and so he has some updates for us.
Thank you, Vincent. Well, ladies and gentlemen, welcome to Victoria. I hope you're enjoying yourself so far. A couple of things you probably need to know about Canada. First of all, your dollar is worth 30% more. That's probably the most important thing. So spend freely. In Canada, we typically give a land acknowledgement, and I'm just going to read out the land acknowledgement for being in this part of the country, that we acknowledge and thank the Songhees and Esquimalt First Nations communities for allowing us to work and play on their lands this week. Some of you probably also know that the Queen passed away recently. Canada is one of the Commonwealth countries, and as a result of that, there will be a statutory holiday to commemorate the Queen's passing on Monday. And I'm just going to read out a small comment here that we acknowledge the passing of Queen Elizabeth of Windsor, who was a remarkable woman who dedicated her life to public service. We are grateful that she used her influence to help shape and enrich the lives of generations within the countries of Commonwealth and beyond. So finally, on to the good stuff. This afternoon, there's both golf and whale watching. Golfers, your shuttle bus will be leaving in the front of the lobby of the hotel at 1 o'clock. Whalers, please congregate outside of the lobby at 2 o'clock. There is no lunch for the whalers. Thank you very much.
All right, let's start our first scientific session. Our first talk is from the University of Washington and entitled Overhead Arm Support Reduces Radiation Exposure During Complex Endovascular Aortic Repair. And Dr. Pujari will be presenting that.
Good morning, everyone. I'd first like to thank my mentors for their guidance and feedback throughout this project. I'd also like to thank the program committee for allowing me the opportunity to speak here today. We have no relevant disclosures. Complex endovascular aneurysm repair is associated with the highest utilization of radiation of any vascular surgery procedures. Radiation physics suggests that tissue density and length directly affect the transfer of radiation through a patient, and obesity has been shown in studies to be associated with a comparably higher utilization of radiation across patients undergoing the same surgeries. The risks of radiation are well known within our field. In particular, the group at UT Southwestern has extensively studied the impact of radiation during these high utilization procedures. And fortunately, for the most part, we tend to fall underneath those industries' established thresholds for safety. However, the risks of radiation-induced harm, such as skin changes and early onset cataracts, are very real. At our institution, when performing fenestrated and branched EVARs prior to 2020, we utilized traditional positioning with arms tucked on both sides unless arm access was required. With the arrival of new faculty later that year, we trialed using overhead arm support for these cases due to this being the standard practice at the new faculty's training in Boston. This led to a change in our practice. After December 2020, all cases were performed in this overhead positioning, which we felt improved visualization and appeared to result in a lower rate of radiation. We designed this study in order to determine if overhead arm support truly improved radiation during these fenestrated and branched repairs. To do this, we conducted a retrospective review. We looked at all patients who underwent repair of a thoracoabdominal aortic aneurysm with a fenestrated or branched device under a physician-sponsored IDE. All surgeries were performed in the same hybrid operating room without any major improvements or modifications to the imaging technology. We included all patients who underwent fenestrated or branched repair for a thoracoabdominal aortic aneurysm within the study period of 2012 to 2022. And we specifically excluded the first 30 patients in the IDE to attempt to account for the expected learning curve with these, at that time, novel and challenging techniques. We compared patients before and after the intervention of using overhead arm support. We looked at baseline comorbidities and anatomic details, and the primary outcomes that we looked at were total cumulative radiation as measured in milligray, the fluoroscopy time, contrast usage, estimated blood loss, and the incidence of palsy of the brachial plexus. Of note, we did have a change in our practice regarding the utilization of brachial artery access. With the approval of the Gore VBX bridging stent graft in 2017, we were now able to place stent grafts in downward going branches with entirely femoral access, which resulted in a significant reduction in our utilization of brachial artery access for these cases. We therefore conducted a subgroup analysis to attempt to account for this and looked specifically at patients who had femoral access only. Here you can see one of our senior fellows who wanted to confirm for himself the safety and comfort of the positioning. After intubation, the patient is positioned supine. The overhead arm support device is brought in from directly overhead and slid underneath the operating table mattress. And the ET tube typically lies just lateral to it on either side. We then use a foam pad and towels to cushion the arms before securing them with an elastic strap. In total, this takes about 2 to 3 minutes and is very quickly familiarized by residents or staff and anesthesia providers. In total, we looked at 145 patients, of which 43 or 30% were positioned with arms overhead. On average, the group treated with arms overhead were 3 years older. However, both groups still fit within the expected age range within the documented literature. Of note, there was no significant difference in BMI between the two groups, which suggested that BMI was less likely to be a confounder in our results. Aside from a higher proportion of males, as well as patients with coronary artery disease in the group treated with arms overhead, there were no significant differences between the two groups. The aneurysms that were treated with arms overhead were on average slightly larger. However, this difference was small and unlikely to have significantly increased the case complexity. And otherwise, there were relatively no major differences between the two groups in terms of Crawford extent, history of prior aortic intervention, or history of prior revascularization of the subclavian. And looking at operative details, fewer patients who underwent repair with arms elevated overhead required brachial access, which primarily reflected the change in practice at our institution. There were more patients that were treated for aneurysmal degeneration of a chronic dissection. But otherwise, there were no major differences. There was an equal number of target vessels revascularized, as well as a similar number of patients who had additional aortic grafts placed at the time of the fenestrated repair. And this held true when separated by looking at proximal TVARs versus distal aortic devices, such as a aortic cuff or a bifurcated piece. In our primary outcomes, radiation was significantly lower in the group treated with arms elevated. This resulted in a 27% reduction in cumulative radiation as measured in milligray. However, this was not associated with a decrease in the fluoroscopy time or the contrast used, which suggested to us that this wasn't a result of fewer DSA runs or shorter operative times. This was a direct radiation reduction for the same procedures. Estimated blood loss was slightly higher in the group before we elevated arms, which we expect was likely due to the expected blood loss with the increased usage of arm access in those patients. However, this difference was relatively small and unlikely to be clinically significant. And very importantly, there was no incidence of brachial palsy in either patient group. We did perform a subgroup analysis looking at patients without arm access. And again, the results were exactly the same. There's a significant reduction, this time corresponding to a 32% reduction in total radiation. And the rest of our primary outcomes were relatively same. In summary, overhead arm support significantly reduced radiation during fenestrated and branched repair. And this was not associated with a difference in fluoroscopy time or contrast usage and incurred no increased risk to the patient. This reduction in radiation occurred despite similar patient characteristics, including BMI, as well as case complexity, in part accounted for by the number of concomitant aortic devices during the repairs. And this was accomplished with a simple intervention using a low-cost reusable positioning device. In conclusion, we suggest that overhead arm support should be considered standard of care for all angiographic procedures involving the visceral aorta. It's easy to implement and does not significantly disrupt procedural flow. And the risk reduction from radiation decreasing applies not only to the patients, but also to surgeons and the operating room staff. And lastly, the implications of this extend far greater than just fenestrated and bandage repair. We now use overhead arm support for all of our mesenteric cases, as well as reinterventions, including patients that have brachial access. We hope that you'll consider using this in your own practice and establishing it as standard of care. And with that, thank you for your time, and I'll take any questions.
This paper will be open for discussion by Dr. Kenneth Ziegler of USC.
Dr. Pujari, thank you. Great talk. Thank you for sending me your manuscript beforehand so we could review it. But now I kind of regret sending you my questions beforehand because kind of answered most of them. But it's great. Like, you know, anytime we're using radiation, and especially if you're in California, you have to learn this fluoroscopy license. Find that ALARA is like the #1 thing that we're looking at. So anything we can reasonably do to reduce that radiation dose for everybody is what we're really going after. It's great that we're seeing a basically 1/3 reduction in radiation from what you guys are doing here. It's nice that you quoted Dr. Kirkwood's paper. And she's been doing great work with this and noticing things like, you know, exactly what kind of exposures we're getting in the OR, what the patients are getting. And then even finding that surgical education such as this will reduce our total radiation dose for everybody as well. It's really great that something as simple as positioning will get such a great result, especially when we're looking at like software things that are getting us 40 to 80%, or you know, even like digital Zoom reducing it 40% for the patient and 60% for us. A couple things I noticed. So you had pretty high radiation dose at baseline before anything like a 3.2 gray down to about 2.2 gray. And you know, I was just wondering like what your actual setup is as far as, you know, your C-arm and things like that. And then it's great that you guys had no positioning injuries and you're treating basically 4 vessels for most of your cases. It's just also from my standpoint, it's nice to anecdotally know there's a benefit to this because I just find better images when their arms are up. And as far as other questions, as far as implementation issues, did you run into anything like pushback from anesthesia, from nursing, as far as getting this all set up? And then did you also look at the radiation dose that the staff and the operators were getting with all this?
Thank you for your questions, and thank you for taking the time to review our manuscript. Regarding the setup, with the arms elevated overhead, it really doesn't impact the positioning of the II. It comes typically from the patient's left side, and we're able to get pretty much any gantry that we need to. In terms of why where our radiation numbers are at, I can't comment too much. And you know, we do everything we can, including all the LR principles, to try and reduce that. And in terms of pushback, there actually wasn't any. We initially didn't have a dedicated device. We started by basically trying to jerry rig and use other potential retract systems to do that. And you know, with that, there was some more added time with it. But once we had the dedicated device, it really just takes a few minutes. Even as a resident, when I was first using it, you know, after the first case, you really understand how it works, and it doesn't take that long to set up. And in terms of the impact to staff, we don't have that data. It's a little bit harder to access some of that data, and it's also not as reliably recorded, and just it kind of depends on if, you know, your dosimeter gets sent in and things like that.
Yes, Dr. Berman.
Good morning, Scott Berman from Tucson. That was a very nice paper, elegant, and something that we would definitely start to implement in our practice. One of the things we've noticed in these complex cases that we do that significantly affected our fluoro time and radiation was the use of directional sheaths, the Oscor or Destino. And I just wondered if you guys had similar changes to your practice when these became more available, and if that was considered one of the factors in your radiation exposure.
We did have a change, and that was part of what I was discussing in terms of not using the brachial access as much, that with the VBX, we're able to use steerable sheets in order to do everything from below. But I don't think we specifically looked at the usage of that in terms of its effect on radiation, in terms of it making it easier potentially to, cannulate certain vessels.
Yes.
Dan Inett from Minneapolis. Were there some patients that just couldn't be done with their arms overhead because of shoulder issues? Did you guys track that?
We actually did not have any issues. We do have, there are occasionally patients who have stiffness or orthopedic reasons, but they're at least able to get some amount of elevation and to a point that we're still able to use the II and for just about any gantry that we needed to.
Dr. Lee?
Really nice presentation, and want to thank you for bringing this to this meeting. I think radiation exposure certainly is on the top of everyone's mind in terms of both safety to the staff, to us, to the residents, to overall wellness and stuff too. Is there a way you can separate out just the fact that over the 7-year period, there's a lot of adjuncts we've all done, I think, to make this better. And I think having even written or presented to this group, 10 years ago about radiation from switching to a hybrid room, I think critiques in the paper were always related to, aren't we just getting better with radiation? And these are small adjuncts that everybody sort of agrees with, to prove that it's actually the arms overhead as opposed to directional sheets, image overlay, coning, digital zoom, better education of our assistants, trainees, people in the room, that's actual the actual sort of effect before we start putting arms up. We've actually started, we've done it in 2 or 3 cases. It is a little bit awkward, and we had to use neurosurgery had this sort of attachment that the arms would fall into. It actually looks like a whale's tail, speaking of our whale watching today. And so we call it the whale's tail. You put it at the head of the bed. That's what we tell the staff. Thanks.
Thank you for your question, actually. And in terms of that, while the separate adjuncts and overall and throughout time, those have improved, it's kind of nice that we were able to do it with the one institution study. All of our patients were done in the same hybrid operating room. There's no improvements in that technology. And while the entire study period was from 2012 to 2022, after taking out the first 30 patients, it really came up to about 2016 to 2022. And within that period, we felt that there weren't a lot of significant other adjuncts we made. Again, we always continue to attempt to use ALARA principles, but the nice thing about the positioning device is it's not something that you have to constantly adjust throughout the case. You set it up at the beginning, and for the most part, you don't have to worry about it. It has that baseline reduction in radiation, but I appreciate your question.
Dr. McGee.
Thanks for bringing your talk to our society. We've gone to using the same technique in our program, and it certainly helps, the lateral imaging and with Dyna CTA at the end. But a couple words of caution, because we have had a couple patients with pretty significant brachial plexus palsies afterwards. So we've gone to a protocol, basically having the patient keep their hands up in that position for like 15 minutes before intubation, just to see if they can tolerate it during that time. So just a couple words of caution, if you're going to adopt this, to think about that.
Thank you for that. And I know that there was a study last year that out of the group at UT Houston that published their results with it, and they also didn't identify any palsy of the brachial plexus. But that, the reason we're even asking that question is because it theoretically could happen, and it sounds like it has in a few cases. I wonder if the device that you use is the same as the one that we use in terms of, like, even, for example, our senior fellow trying it, it's actually pretty comfortable. It doesn't, I think if you're able to get the exact position, it really shouldn't result in that. But again, I wonder if the device that you guys are using is different.
Yes, I think you were here first.
Sure. I just wanted to answer a couple of questions. I think Amit, great job on your talk. One of the questions that came up was, these are high dose procedures. We know that. I think important to note in all of this, these are all thoracos. So none of them are juxtarenals. They all have coverage all the way up. So these are pretty complex procedures. And when you look at it, even in the ARC kind of globally overall, we're still kind of right in the middle of the folks who have IDEs around the country. So, but that being said, I think there's always a push to drop these radiation doses. And I think that's what prompted this. I've been doing arms overhead for about 5 years now. And I can say in several hundred patients, I've actually never seen a brachial injury. And in the other reports out there, I think there's very few, if any of them. One of the things we did incidentally is actually put neuromonitors on them to look and see. And on one case, we actually did see some shifts, but the patient was totally asymptomatic with nothing there afterwards. The other kind of comment that came up was in regards to steerable sheets. We were using steerable sheets prior to this change, I would say. Basically from 2017 onward when we had those VBXs. So I think that kind of takes that out of consideration in terms of a confounding factor.
Thanks, Dr. Zoll. We have time for one more question, I believe. Dr. Fujitani.
Good morning. I think you bring up a really important question. My question has to do with these staff that are working on the patient. You clearly demonstrated that there's decreased radiation exposure to patient with this, and that would seem logical. I'm just wondering if there might be some difference in exposure to the staff upon scatter radiation, depending upon where you place your fluoroscope at. And do you do any real-time monitoring of the staff that are doing the procedure so that you can see what that is? And if you do have the ability, it'd be interesting to see whether or not there might be a difference between arm down, arms up, and how much scatter radiation there might be, because that's an important component of radiation exposure.
Thank you for that question and that suggestion. We have not, at least at this point, used any sort of real-time monitoring to detect that. Every person in the operating room is wearing a dosimeter, and we can at least collect their radiation exposure afterwards and attempt to look at that. But right now we have not done that. I think it's a really great thing to looking forward to towards another study.
All right.
Thank you so much.
Thank you.
Next, I'd like to, next we'll bring up Dr. Kang from Loma Linda University Medical Center. Discussion regarding gender disparity and developing a convolutional neural network specific for the identification of infrarenal abdominal aortic aneurysms.
Thank you. Good morning. Thank you to the Society for letting us present our work. I have no disclosures. Neural networks have become very popular as it's being used now to do disease modeling and also the prediction of outcomes. And what a neural network is basically a computational learning system. It uses a network of functions to understand and translate a data input of one form into a different form of output. In a computational neural network or a convolutional neural network, a CNN, basically that is trying to replicate the visual cortex. So looking at the diagram, it's not trying to memorize that specific slide as an aneurysm, but the CNN is going to try to understand the concept of aneurysm globally as a whole and interpret it as AAA. Now, we previously reported our convolutional neural system looking at VGG16 architecture and its ability to model with 99.6% accuracy in identifying an infrarenal abdominal aneurysm. It's got a less than 1% misjudgment. And as you see through different variations of training through selected images, balanced images, and unbalanced, we can maintain a high degree of accuracy with an AUC of basically 99%. Now, as these neural networks are becoming more popular, it's come up that it's actually got an element of bias, right? You can imagine if there's a biased data input going in, its output is actually going to be biased. So how do we fix that? So algorithmic fairness is now an emerging field of machine learning, and it's trying to mitigate the differences in modeling outcomes, looking at social, gender groups, et cetera, et cetera. And just to take a step back, right? Why is this important? It's important because you have to look to see what an ideal model is versus what a realistic model is. So an ideal machine learning algorithm actually is a blinded model, and it's a puristic model that can detect outside of, for example, gender, race, geodiversity bias. But it's also not a realistic model, right? Because you can see that depending on your patient population and your algorithms developed, it may not be generalizable, which leads to probable errors of either whether it's a realistically applicable model. So where is that balance, right? How do we make a model that predicts fairly, but at the same time doesn't become biased? So our aim, when we looked at our algorithm and its architectural design, we wanted to see to determine if gender training and testing factors can affect the accuracy of our CNN model. What if we were biased? What if the original AUC that we gave you was actually biased for a certain population, in this case, a certain gender? So what we did is we took our original algorithm, still using the VGG16 architecture, and designed 6 new model algorithmics to test. And I'm going to go over this in detail only because it's going to impact the way the data is going to be presented. So in the original model, we used a composite set model to train through different epochs and generations to get an outcome for a composite output. What we hear now is we split it up to different forms of input and output. So we did male-only training to only have male-only testing, female-only to only female-only testing, male-only training to composite testing, female-only training to composite testing, composite training to male-only testing, and composite training to female-only testing. So in using these 6 different algorithms within our architecture, we then looked at the accuracy, and the AUC was then looked at to see how much it could meet its baseline. So out of the 6 algorithms that we trained, 5 of the 6 algorithms were able to maintain basically an over 90% sensitivity, specificity, and overall accuracy, replicating the original composite training model that we had performed. The one model that actually did not do well was actually the female-only training model to a composite testing. It actually was statistically lower in terms of specificity of only 88% and overall accuracy of 93%. And we found that that was really interesting. Using the confusion matrix, think of it as a 2x2 model. We looked at the female-only training model and noted that there was a high percentage of false positives of 231. But if you look at the companion model, where it was only male testing to composite output, it actually didn't have the same problem. So where was this issue? We even artificially augmented the female population within epoch testing to give you either a matched cohort or an unmatched cohort, right? To look at an ideal model versus a realistic real world ratio model. And we still could not actually optimize the specificity and accuracy for a female only training model. When we looked at the error analysis, tried to dive into the black box within the deep learning system, we found that overall for false positive analysis, segmentation errors was the biggest issue. Whereas with the false negative, it was a mishmash of just presence of thrombus or the size of the aneurysms. So in summary, we found that in our preliminary analysis of our own CNN model, within its modeling original architecture, the female-only gender training has a reduced accuracy. And the reasons for false positive negatives were stated previously. However, this is not seen in its companion model, which is the male-only training for composite testing. So we're trying to figure out where that difference is, right? Is it the actual raw data input? Now we're looking actually at the image acquisition and all the variables, especially the nonlinear variables that may have been input without our notice. The limitation, of course, is this is a single model capacity. It's only on the VGG16 architecture model. There's other architecture models and public domain that is available. We did not test that because that's not within the realm of our computational system. We are building a second AI core lab with an augmented VGG18 model. So we will be running the generalizability of that. And the sample size, if you want to think of it, is actually underpowered, even though we boosted the performance of this model by reiterations of epochs by thousands. But we really, within this limited set, could not look at the bias, the variance, the actual issues of underfitting, overfitting, and the hyperparameters that could be used to make this a better model. So overall, the conclusions are that machine learning models are being looked at as a Hail Mary, right? But they're actually susceptible to bias, as with all basically clinical types of studies that we've known previously. We just don't really know how to fix this within machine learning. We don't know the deep learning systems well enough. And for our specific CNN model, that we found that there's a female-only gender training bias, and that has a reduced accuracy. And we need to work on this more, because as more and more of this gets published, right, we need to figure out where in the machine learning world can we have an ideal model versus a realistic model, and where bias plays into all that. I want to give a thank you to my AI Core Lab and my national and international collaborators, and I'll take any questions.
Please. I think I understood about 90% of the words you said. So I'd like to bring some, can you explain a few things to me? I don't actually know what segmentation errors are. And so I was hoping you could explain a little bit about that, and then how things, the thrombus and things might be affecting some of the other errors or differences that you see.
Right. Thank you so much. So imaging segmentation is a province within visual based AI algorithms. So I'm just going to use this mouse as an example, right? When we actually look at this, we computate it as a mouse. We not only differentiate the colors, but the borders of the colors, but also the 3-dimensionality of it. Image segmentation is asking a computer to divide up all these segments and reprocess it itself. So when you look at it using your visual cortex, my eyeballs, I see red, I see black, I see the little roly ball here, but I also process depth, I also process size, I also process maybe density and weight, right? All these things that are going on in your brain that you're not really thinking. Image segmentation takes the machine portion to do that. And as image segmentation gets more sophisticated, it's processing the way you're looking at this or looking at me. And that's really what that is.
We'll go to the mic on the left.
Thank you so much for this presentation. I think it's a really interesting and important discussion about how bias isn't eliminated by big data models, but maybe it's just a little harder to identify because of the convolutional nature of the layers. So VGG 16 has like an accompanying module for a CAM, a class activation map. So you can actually see in the layer prior what sort of the pre-cortical areas you're interested in before you actually convolute them to your AAA versus not AAA. Right. I was curious whether you were able to look at those as sort of a way to indirectly view how the layers up until then might differentiate between your different classes of men and women. I was also curious if you were still using a propensity match prior to entering your images, because some of the methods there in detecting bias might be a little more obvious for those classical regression methods if they're part of the pipeline.
So excellent question. That actually relates to our prior publication that I mentioned. So in the original study, we looked at propensity match aortas plus negative aortas and did basically what we would call like a deep learning sub-analysis to see where the error margins were. No, so for example, using Dr. Humphrey's question, thrombus, right? We found that thrombus was a big marker of misjudgment, mostly because the machine could not in its mind segment out the actual outer wall of the aneurysm versus where the thrombus was. We then cross-checked that with heat map overlays to see where the actual margin of error was, how thick the thrombus had to be, for example, things like that. And so we did that in the original study to find the AUC itself. So we did that in different segments of the training algorithm. So we originally had selected images, then we had the matched and then the unmatched images. And that's how we did it. We didn't look at it in terms of gender per se. At that time, we were more focused on boosting our performance by the anatomic parameters to make sure the machine could actually do what it said it did. But we will actually look at that in the next layer, right? Because it's more than just gender. It's also race. It's also, geo location, which it's been reported that, these deep learning machines, especially the group out of Emory, are saying that out of gender neutral studies, they can predict race and gender. So how is it doing that, right? It's kind of scary because it's computing things that are very non-linear to us, and they're taking these multi-dimensional variables and kind of putting it together. So we're going to do that next, and we're going to augment. Obviously, we're building a second AI core lab. So thank you for your question.
Thank you so much. I'm sorry, we're going to have to move on. But thank you for the questions.
Our next paper is from University of Texas Southwestern and sponsored by our member, Dr. Fred Weaver. It's entitled Understanding Who Benefits from Endovascular Aortic Repair in Those with Chronic Kidney Disease. Will be presented by Dr. Curry.
Hello, everyone. My name is Mitri Fori. I'd like to thank the committee for the privilege to present our work titled Understanding Who Benefits from Endovascular Aortic Repair in Those with Chronic Kidney Disease. These are our disclosures. Endovascular aortic repair has become the primary treatment modality for AAAs due to its significant reduction in perioperative morbidity and mortality when compared to open repair, specifically in patients with multiple comorbidities. Chronic kidney disease patients represent a specifically high-risk group of patients with an overall increased risk of death and cardiovascular events compared to the general population. However, little data exists regarding which patients with CKD may ultimately benefit from repair. We utilize the Gagny Index, which predicts the one-year mortality based on a set of comorbidities. This combines conditions from the Charleston Index and the Elix-Hauser system, and we modified this based on rupture risk for AAA size, which I'll discuss in the method section. And we use this to predict the one-year mortality without repair in patients with AAAs. The aim of this study was to determine which subset of CKD patients are more likely to experience a survival benefit following elective EVAR for AAAs. The VQI EVAR database from 2003 to 2020 was queried. Patients were excluded if they underwent non-elective operations, had missing data for variables of interest, and had prior kidney transplants. The primary outcome was 1-year mortality. Secondary outcomes included 30-day mortality, length of stay, and major adverse cardiac events, also known as MACE, which was a composite outcome variable including dysrhythmias, myocardial infarctions, and congestive heart failure. Patients were classified according to CKD stages as defined by the National Kidney Foundation. In total, there are 6 stages, 1, 2, 3A, 3B, 4, and 5, defined by their baseline GFR. The Gagny index is calculated based on a set of comorbidities, each having a certain weight to it. The accumulation of these weights provides a patient with a Gagny index that has an associated 1-year mortality with it. As you can see here, peripheral vascular disorder is included in the Gagny index, which encompasses AAAs. However, this is irrespective of whether they've been repaired or not, and irrespective of their size. Therefore, we modified this Gagny index according to patient's aneurysm diameter to provide us a predicted 1-year mortality of untreated AAAs, calculated via the following. The predicted 1-year mortality based on the Gagny index, excluding the point associated with the presence of peripheral vascular disease, and this was replaced with the 1-year aneurysm-related mortality without repair, which equals the 1-year aortic rupture risk based on aneurysm diameter, as shown on the table on the left, times 0.80, which is the mortality associated with a ruptured aneurysm. The table shown here shows the baseline characteristics of all the groups. It is a busy slide, but in short, patients with more advanced stages of CKD had a higher comorbidity burden. The table shown here shows the distribution of Gagny index and AAA diameters. Again, patients with more advanced stages of CKD tend to have higher Gagny indexes. Patients with more advanced stages of CKD were less likely to be treated for aneurysms less than 5.5 centimeters, whereas they were more likely to be treated for aneurysms 7 centimeters or greater. In regards to operative characteristics, patients with more advanced stages of CKD had longer procedure times. Patients with CKD4 had the least amount of contrast used during their operation. And while there were statistically significant differences in estimated blood loss between these groups, this did not appear to be clinically significant. And there were no differences in conversion to open rates between the groups. The overall 1-year mortality for the cohort was 5%. In regard to perioperative outcomes, patients with more advanced stages of CKD tended to have longer lengths of stay, had higher rates of MACE, and had higher 30-day mortality rates. Shown here is a Kaplan-Meier analysis out to 12 months, stratified by all the stages of CKD. Patients with CKD 1 and 2 had the best cumulative survival, followed by CKD 3A, then 3B. And patients with CKD 4 and 5 had the worst cumulative survival. On Cox proportional hazards regression modeling, patients with CKD 3B, 4, and 5 was associated with 1-year mortality, with increasing hazards ratio with increasing CKD stage. The table shown here shows the actual 1-year mortality with EVAR versus the predicted 1-year mortality without EVAR, stratified by both CKD stage and AAA size. Patients with CKD 1, 2, 3A, and 3B had a better actual 1-year mortality with EVAR than the predicted 1-year mortality without EVAR across all AAA sizes. In patients with CKD 4, there were no differences in the actual 1-year mortality with EVAR than the predicted 1-year mortality without EVAR across all AAA sizes. And in patients with CKD 5 being treated for aneurysms less than 5.5 centimeters, there was a worse actual 1-year mortality with EVAR than the predicted 1-year mortality without EVAR. For patients with CKD 5 being treated for aneurysms between 5.5 and 6.9 centimeters, there were no differences. And in patients with CKD 5 being treated for aneurysms 7 centimeters or greater, we found that the actual 1-year mortality was better with EVAR than the predicted 1-year mortality without EVAR. The limitations of this study are due to its retrospective nature and all the inherent biases associated with it. In addition, the Gagny index only includes renal failure as one of its variables, so known as CKD 5, but not the lesser stages of CKD. Therefore, in the patients with lesser stages of CKD, the predicted 1-year mortality without EVAR may be underestimated. We also only utilize diameter data and lacked anatomic data to predict the aneurysm rupture mortality risk, which may not be completely accurate. And the data regarding 1-year rupture risk are primarily composed of male patients, whereas female patients tend to have a higher rupture risk as similar sized aneurysms compared to males. Nonetheless, in conclusion, patients with CKD 4 and 5 represent a high-risk group who may not benefit from EVAR utilizing traditional size criteria. CKD 4 and 5 patients with AAAs less than 5.5 centimeters may not benefit from EVAR. And EVAR may need to be reserved for AAAs between 6 and 7 centimeters in those with advanced stages of CKD, unless there are other concerning anatomic characteristics. I'd like to thank my mentors at the UT Southwestern Medical Center, along with those at Keck Medical School of Medicine of USC. Thank you.
This paper will be open for discussion by Dr. Gail Tang.
So I'd like to thank the society and the program committee for allowing me the privilege of discussing this very proactive paper. And I'd also like to thank the authors for providing me with the manuscript well in advance of the meeting. So I think the conclusions are actually a little less pronounced than the data shows, which really showed no benefit for anybody in CKD stage 4, and that the CKD stage 5 patients really only benefit with the aneurysm greater than 7, as opposed to your conclusion, which says that maybe not for anybody less than 5.5, and maybe consider for 6 or 7. So I think there your data actually is a little stronger than what you concluded. This is a very relevant topic because we know that from other studies that patients with CKD are more prone to have AAA. And so then it becomes a very relevant question of who should we actually be treating. Certainly the Society for Vascular Surgery recommends that treating only for greater than 5.5, even though that's your data suggested for the smaller sizes, even for the lesser stages. So having said that, I do have several questions for you. Question number 1 is that you've used old data from the previous ATOM trial and a UK small aneurysm trial to judge your rate of progression and rupture risk for AAA. And we don't actually have rate of growth or rupture risk for patients with CKD. So you don't know whether it's greater or lesser than the ones that were included, and the ones they were excluded from the ATOM trial and the UK small aneurysm. They don't actually list this CKD as a risk factor, so you could actually be underestimating the risk of rupture for these patients. Question number 2 is that VQI is kind of a procedural database, so the only people who make it into the database are people that a surgeon chose to operate on. So that presumes that they all passed the surgeon eyeball test. And so some of your predicted versus or actual survival versus predicted survival could be based on surgeons cherry picking the patients with CKD to operate on, and they may be passing on the more severe ones. And that gives you an apparent survival benefit, which is not actually necessarily from protection from aneurysm rupture, but is actually due to surgeons choosing to operate on the healthier patients. And if you look at the number of people with Charlson comorbidities, there is a greatly decreased number of people who got operated on who had severe mortality or severe comorbidities. Question number 3 is that there is a certain percentage of patients that you speculate in the manuscript, and not presented here for time limits, I'm sure, where they were treated for aneurysm less than 5.5, but they, about 20% of them had large iliac aneurysms. And we don't really have the greatest natural history in terms of when to fix iliac aneurysms. So can you speculate as to what size threshold should we be using for CKD patients, especially stage 4 and 5, who have iliac aneurysms as opposed to AAA? And the last question is back to women because of the same problem. So based on your data, what would you suggest should be the size threshold for women with CKD 4 and 5? Because society says operate at 5. And so what would you say would be the size threshold for a CKD stage 4 or 5 woman with a AAA? Thank you.
Thank you, Dr. Tang. I really appreciate that. In regard to the CKD rupture risk, this is an excellent point. It may be, in fact, not be warranted as there is no good data available to delineate the growth rate in these patients. Patients with advanced stages of CKD may have increased or even decreased rupture risk of similar sized aneurysms compared to the general aneurysm population, none of which is actually known. There have been studies demonstrating an increased incidence of AAAs among CKD patients when compared to the general population, but whether this translates to an increased rupture risk is unknown. Given the increased mortality rate following EVAR in advanced CKD patients, natural history studies of CKD patients are likely warranted to better understand this. In regard to the question of the actual mortality rate possibly being artificially low in advanced CKD patients, as these patients may have been cherry-picked by the surgeon, is very valid. I also suspect that the actual mortality rate would have been higher if the surgeons were to operate on all advanced CKD patients. You're correct in that this is not a natural history study, and therefore it is impossible for this study to elucidate this. Nonetheless, the significantly high perioperative adverse outcomes and poor one-year mortality rates in these patients raises concerns and questions the application of traditional size criteria in these patients. In regard to your question about the size threshold for an iliac aneurysm in patients with CKD end-stage renal disease, this is a difficult question to answer as the natural history studies for the iliac aneurysms are not as well investigated compared to AAAs. Some studies suggest that the average risk of rupture for an iliac aneurysm is approximately 5.6 centimeters, but this still doesn't tell us what the risk of rupture is at certain diameters. If that data was available, then one could use the Gagny index to understand what the associated one-year mortality is for a patient due to their underlying comorbidities and balance this with the rupture risk of the iliac aneurysm for that specific size. Therefore, I think for now, we are forced to use a 3.5 or 4 centimeter diameter cutoff until the rupture risks are stratified by diameters available. In regard to the question about the size threshold for women with CKD end-stage renal disease, I think it's likely that the 5 centimeter cutoff may not be appropriate in this patient population. Further, although I did not specifically highlight this in the talk, female sex was associated with one-year mortality following EVAR in the Cox proportional hazards regression model. Therefore, women with advanced stage CKD are likely to be at even higher risk of one-year mortality following repair. This data is somewhat available in the VQI, and it will be an important analysis that needs to be conducted, which I will do and add to the paper. So thank you for bringing that up.
Very nicely presented. Congratulations. I think one of the risk factors of future mortality after operating on patients with CKD is progression of their CKD from the procedure. I think the VQI would be a reasonable database to look at rifle sort of AKI, meaning progression from 3A to 3B, and whether that turns out to be a risk factor for future protection from death. Did you look at that at all in terms of progression of stage, like at 1 year? How many people went from 1 to 2, 2 to 3, 3 to 4, 4 to 5? I think that would be important to data or worth another project next year.
Yeah, I think that's a great point. It's sort of in terms of investigating the renal decline in these patients after they, undergo EVAR would be a very important thing to do. And also, we also don't have, one other thing is we don't have the data to suggest how these patients have been declining or whether they're plateauing even before they got EVAR. Because obviously the patient that is experiencing renal decline and then gets an EVAR and then continues to renal decline is different than the patient that is CKD 3B all the way throughout. So these are further things that we have to elucidate.
Hi, I'm Napolitano from OHSU. There was a paper published at JVS in 2015 looking at the rupture rates of large aneurysms unfit for repair to get a more modern natural history of aneurysm rupture rates. And that actually showed lower rupture rates than what you demonstrated here. I'm wondering if you considered using that data to look at your predicted rate of rupture. If so, and if not, why not? Or whether you think there might be a value to using those more modern numbers compared to what you used from the ATOM trial.
Yeah, I did not consider that, but that's something that we can consider.
And Dr. Jazari, last question.
Did any of your patients go on to have transplants, or was that something that you looked at all? Your chronic kidney 4 or 5, and then were they also some of them on the transplant list? Because sometimes you get calls from the transplant surgeon, are you going to fix this aneurysm or not?
So in terms of being on the transplant list, I don't think that data is available on the VQI, and I don't think the data in regards if they received a transplant is also in the VQI. I think there is some data to suggest there is some long-term follow-up data in terms of creatinine in the VQI, but it's not entirely complete, but that is some subset analysis that I could do.
All right, thank you. Our next paper's from Minneapolis VA and entitled 20 Years of Follow-Up After EVAR, Lost and Found, presented by Lisa Smith.
Slide switched. Thank you.
There you go.
Hi, I'd like to thank you all for the opportunity to present today. We have no conflicts of interest. So it's well defined in the literature that surveillance after EVAR is an issue. So we see in the literature that 50% loss to follow-up is tolerated. So one of our primary objectives was to determine the reason for care gaps, return to care, and the effect of a nurse-managed database on EVAR surveillance compliance and follow-up. So definitions for complete follow-up, care gaps, and loss to follow-up vary in the literature as well. We took a conservative definition of a care gap and identified that as any gap greater than 2 years where there was no EVAR-specific imaging, and then any imaging gap that persisted until death or was a living patient that was unrecoverable in our recovery process was considered lost to follow-up. This was a retrospective chart review from 2001 to 2022. And we identified 921 patients, 511 had complete care. The other 44.5% experienced at least one care gap that was greater than 2 years. Patients experienced anywhere from 1 to 4 gaps. And then these gaps lasted anywhere from 2 to 12.5 years. So of our patients that expired during this process, we found that 173 had died while being lost to follow-up, and that at least 12 of those had died with aneurysm-related mortality. Of our living patients here, we identified 117 that were lost to follow-up, and then we initiated our recovery process. During this time, we recovered 98 of those patients to care, which is 84%. And we identified 12% of those required secondary interventions to prevent aneurysm-related mortality. So when we look at the demographics of those two groups, patients receiving complete care versus patients experiencing care gaps, we see that our complete care patients are significantly older. They're more likely to have comorbidities such as coronary artery disease, cancer, congestive heart failure, and be on an anticoagulant. So maybe it's not surprising that when we look at the survival curves of these two groups, we see that the red dashed line represents our complete care group. They have decreased survival. One hypothesis for this is that these patients are older and have more comorbidities and are more likely to be connected to the healthcare system. So now that we know patients are lost to follow-up and we know that they are older and have more comorbidities, we were curious to see if we looked at patient factors, system factors, and unknown factors for these two groups of patients, looking at reasons, lost to reasons why they were lost from care or returned to care, what differences would we see? So of our 410 patients lost to follow-up, we identified 475 specific gaps. We identified 185 patients who had return to care reasons. The remaining patients were lost to follow-up at the time of recovery. And what's important to note here is that total system factors account for the majority of reasons patients are lost from care and also returned to care. So when we look at the proportion of patients receiving follow-up over our 22-year period of time, what we see is that when you have an RN case manager noted by the double head arrow, you have a significant association with higher follow-up compliance. And if you look at the asterisk, which identifies individual staff turnover by year, you will see that staff turnover is associated with decreased compliance in those years. So in conclusion, we know that EVAR surveillance compliance is an issue in long-term follow-up, and that many of our patients are lost to care. We know that system factors, not patient factors, account for the majority of those losses, and that a nurse-managed database can help ameliorate the effects of those system issues. And I'll take any questions you may have.
Thank you. We have time for a couple questions. Dr. Abuzamzam and Dr. Dahlman.
Yeah, thank you very much for that. It's just a question of how much effort, how much time is needed to do this and who supports that cost?
That's an excellent question. So I work on another study for Dr. Daniel Einot, and I did this in my free time. So a couple hours a week, we just pulled data by CPT code, found all of our living and expired patients and gave them a call and said, hey, are you getting care outside our system? Can we get you reconnected to care? So it's really a simple process. We're now building a database that's very automatic and hiring another advanced practice nurse to help with the recovery to care process.
Dr. Dahlman.
Yeah, that's a great presentation, highlight an important problem. Obviously, there's one solution that fits best in a closed healthcare system like VA, that others that might need to be applied to larger fee-for-service health system. I just point out that FDA is also concerned about this. There was a retreat now almost a year ago, a two-day retreat talking about the failures in the approval process for the AFX device, Endologix, and then followed by a white paper in February where the FDA lays out their expectations for the future of endovascular aneurysm repair. And right now, they include an expectation that there's a system in place for 10-year follow-up that includes an image component as well. And the VQI Vision Collaborative has proposed a solution that would involve 10-year linkage between the initial VQI data entry and then the claims data that's available through the vision process. So this has obviously reached a huge national issue where FDA feels the current follow-up system is inadequate for endovascular aneurysm repair, and they're expecting a solution within the next year or two that would involve, as I say, up to a system that can provide 10-year follow-up to ensure just what you're talking about.
Thank you. Thank you for your comments. I think it is important to note that, of those patients coming back for reinterventions, there is monetary capture for those. And then also an APRN can charge for billing, while a scheduler and a nurse can effectively complete the calls without adding too much cost to your system. Is there time for one more?
Yes, there is. Go ahead.
I noticed that you had about 12, I think, aneurysm-related mortality in the patients that had a care gap. But did you have any aneurysm-related morbidity or mortality in the patients that didn't have a care gap? And if there's a big difference, then obviously that highlights even further the importance of not having that care gap.
No, we had no aneurysm-related mortality in our patients experiencing care gaps. I'm sorry, I misspoke.
Oh, go ahead.
In our groups that had complete care.
Great. I think the one thing is to think about is, within the VA system, is there any thoughts of, rather than utilizing an actual person or a coordinator to help improve your follow-up, of utilizing the electronic medical record, something that utilizes systems that are already in place that then could help promote follow-up?
As in a reminder system or?
Yes, something similar.
So I think by automating the system, so right now we're building a database that it automatically determines if you had imaging and clinic follow-up, and then those patients are just moved to the next opportunity that follow-up is due. The reminder system works well, except for when staff turnover occurs and the reminder goes into space and there's no follow-up, then there's no person to catch the mistake. So we're not quite there yet, I don't think.
Our next topic is presented by Wei Ho from Stanford Healthcare. The most privately insured patients do not receive federally recommended abdominal aortic aneurysm screening. And this is also a candidate for the High Resident Award competition eligible presentation.
Good morning. Thank you for the opportunity. I have no disclosures. Since 2005, there's been federal recommendation for one-time ultrasound screening of ever smoking patients, male patients between the age of 65 to 75 for abdominal aortic aneurysms. However, compliance in the last 2 decades has ranged from 12.5 to 72.5%.
integrating healthcare systems with individual institutions, suggesting that there's a wide amount of institutional variation that's not just explained by regional differences. In order to better elucidate what is actually the barriers to AAA screening, we turn to the IBM MarketScan Research Database, which is a comprehensive private claims network containing inpatient data and outpatient for over 250 million claimants. Sources are drawn from private insurers and linked to Medicare, Medicaid data when these patients obtain supplemental insurance, ultimately representing a comprehensive source of medical activity for covered patients from 2006 to 2017. We undertook a conservative estimate of who is and who is not being screened for AAA in this cohort by extracting males enrolled from age 65 to 75 with any history of prior smoking. Exclusion criteria included axial abdominal imaging, such as a CT or an MRI, which would obviate the need for an ultrasound during the study period, a prior diagnosis of abdominal aortic aneurysm, and prior diagnosis of connective tissue disease, which would change the dynamics of needing aortic screening. Our primary outcome was screening, which we identified as being a complete abdominal, retroperitoneal, or aortic ultrasound via CPT codes. We included covariates that we thought would modify this outcome, such as geographical region, state, metropolitan statistical area, which is more colloquially known as sort of urban versus non-urban, and comorbidities known to influence AAA trajectories, such as hypertension, coronary artery disease, and diabetes. We combine these into a multivariate logistic mixed effects model, which allows us to very nicely identify how different covariates can non-linearly or on a group level influence the outcome. Understanding that different states might come from a different level of baseline screening due to local policies, we accounted for them as a random intercept and evaluated fixed effects, including cardiovascular comorbidities and urban status. On purely univariate analysis, we identified a 38.7 overall screening rate in the cohort of 35,000 eligible patients. Looking at this more granularly, there's no regional differences if you look at sort of Northeast, North Central, South, and West. However, patients outside an urban statistical area were far less likely to be screened. Medical covariates that would possibly raise suspicion for the need to screen for AAA, such as hypertension, coronary artery disease, and hyperlipidemia, were more enriched in the screen cohort, suggesting that there is a level of clinical concordance as to who gets chosen. It's sometimes really helpful to see things more on a regional scale with a heat map. So we can see that on a state level, screening compliance is ranging from about 25% to 50%. So nobody is really getting even a C in this sort of score. Folks are really not getting screened across state levels. And there's not really a regional difference. You see higher performers are such as Montana, Washington, Louisiana, for example. But there's not one specific multinational region or multi-state region that's outperforming. There was some hope for the future in that screening activity seems to be increasing annually over the study period in this cohort. But more importantly, on a multivariate analysis, we're controlling not only for individual states, but also controlling for these comorbidities in which screening is more enriched. We still see that living outside of a metropolitan statistical area is significantly associated with a lower likelihood of screening at an odds ratio of 0.92. Putting this all together, it's a real pleasure to present this at the Western because of the prior history of presenting abstracts here at this conference related to aortic screening. We have previously actually witnessed some of the best practices to screening alerts. On the left, Lee et al. In the VA system achieving 84% attendance by manual patient contact, and then Hai et al. In Kaiser, Northern California, demonstrating how best practice alerts embedded in the medical record resulted in significant improvements in screening rate from the mid-50s to a mid-80% compliance. And ultimately, this study brings light to these regional disparities in vascular care that we're starting to see echoed in other forms of vascular surgery. So Fenneroff et al. Identifying that patients living outside of dense urban centers like Philadelphia, Miami, Detroit, and Atlanta, when matched in similar regions, are having a higher rate of amputation compared to limb salvage. And then Barshis et al. In a study released in the JVS recently, evaluated how in Texas, you're more likely to get a repair for your intact abdominal aortic aneurysm when you live in a metropolitan statistical area as opposed to living out of it. So I think this work somewhat extends these studies and shows not only in disparities in vascular outcomes, but also disparities in early diagnosis and detection, which is so essential for AAA given the morbidity of rupture. So some limitations to the study. This is obviously a retrospective analysis of claims data. We're using non-inferential methods here. So I'm not here to make a causal claim as much as to couch what our findings are in other literature that makes sense and should raise the awareness of the need to improve screening in our patient population. There's also miscoding and billing errors that are inherent to claims data. We don't have access to patient courses to verify this manually. Additionally, not everyone eligible for federal screening should be screened. A 75-year-old patient with metastatic cancer who's going to hospice isn't someone who should be screened, even if the federal guidelines are what they are. However, I think we've done a very good job to try to create a very conservative estimate of who should be screened. We're allowing providers the maximum amount of time, 65 to age 75, to screen their patients. We're excluding all prior axial imaging, although in the real world, many providers don't know that so-and-so got a CT scan 3 years ago at another hospital. And we're also pre-selecting, by the nature of the eligibility period, a patient cohort well enough to live until from 65 to 75. So you still might have patients who say, hey, I just don't want to be screened. It's not going to change my healthcare decisions. But I think we did a good job of isolating a cohort where these are really some of the best performing patients and the most eligible for screening who still are receiving overall, less than 40% compliance on a national level. So in a sample of 250 million claimants, we found that there's still a lot of work to be done in improving AAA screening. Living outside a metropolitan statistical area was independently associated with lower likelihood of screening, even more so when you adjust for clinical covariates that might drive physician suspicion. And ultimately, we think that efforts to improve early AAA detection should target non-metropolitan areas, in addition to modifying general incentivization strategies. Screening now has its own CPT code. It's federally recommended, so it must be covered by insurance, but there's clearly more that needs to be done to actually getting these patients in the door. These are some of my acknowledgements with regards to funding sources. Looking forward to any questions.
This presentation is up for discussion by Dr. Nii Kabu Kabutey from Harborview, UCLA.
Harvard UCLA, thanks. Thank you for your presentation. Thank you to the program committee for asking me to discuss this excellent and interesting paper. Thank you to the authors for sending it to me so early that I lost it in my inbox. And I congratulate you on a study showing that, in the real world, in not a closed healthcare system, that we're only screening about 38% of the patients who should be getting screening. I wonder if this is a bad news, good news kind of paper, meaning the bad news is we're not doing a really good job of screening. The good news is that as we get better at this, perhaps we'll see fewer and fewer ruptured aneurysms. I note that in the 8 years that you studied from 2008 to 2016, there was a linear increase, which you mentioned in the incidence of screening in that calendar year. Do you have any sense what has happened in the 6 years since 2016? Could we expect that linear increase to continue? And if it did continue, do you have any sense of what percent and where we might be for screening? Would be my first question. And the second question couched within that is, when we look at the UK experience, and of course they've been at screening longer than we have, despite multiple different strategies, they're at about 75%, and it almost seems as if that is sort of the best we're going to do. Beyond that, were you able to look at factors that affected or impacted screening? We heard yesterday about area deprivation index. We heard about food deserts. The UK talks about their multiple deprivation index as being a factor for decreased screening, and we know that it's a factor in terms of the social determinants of health. So were you able to identify that in this subgroup? Are patients who are at risk for other issues at risk are they also at risk not to be screened? You mentioned that the consolidated healthcare systems, the VA and Kaiser, do a really great job of screening these patients, and I appreciate the fact that you're up for the Bob Hire Award and you actually referenced Dr. High in your presentation. Nice move there. Were you able to look at, because private health insurance is different, right? And there are private health insurance that are patients that are within a consolidated system. And really what I'm getting at is, did you have a sense of whether an EMR system associated with these patients impacted their screening? And then finally, your strongest predictor of screening were patients with CKD. Do you think that that was because the nephrologists are doing a better job of screening for aneurysms, or was that because these patients might just be getting ultrasounds along the lines of their care for their renal disease? Thanks for an excellent presentation.
Thank you very much for your questions. First, regarding the sort of linear increase where we're seeing in screening, one caveat, it's a little misleading because we're giving these people 10 years to be evaluated. So these are actually pretty much, if you go from 2006 to 2018, two cohorts of patients who lived from 2016 to 2006, 2016, 2007, 2017. And so what we were really seeing in that is that patients are likely to be screened later in life, whereas incident screening is measured a little differently because we're using the shifting time window of 10 years of eligibility. So ultimately, our data sort of capped at 2016, but we are presenting or submitting new abstracts looking at the incidence of screening as more of a discrete variable rather than that of a shifting time window, which is a better way to answer that question. With regards to social determinants of health, I think it's incredibly important to understand the intersectionality of patient life inside and outside the hospital and how that drives screening, which is very much an outpatient activity. Unfortunately, just based on the huge spread of patients that we had across regions, once we tried to look at county level indices such as ADI and like even county level income, the cell sizes for each patient in its zip code are so small that it prohibits our ability to go further because it's actually a danger to identification. So it's kind of humbling when you have 250 million claimants and all of a sudden you're like, oh, I have less than 10 patients per cell. So that was sort of a limitation based on our data source and how we can responsibly use claims data. With regards to kidney scans, we actually did not include renal ultrasound specifically. I know a good ultrasound tech can sometimes detect a AAA incidentally while they're looking at a kidney stone. But we specifically wanted to pick qualifiers for screening that would reliably always pick up a AAA. And so we picked a complete abdominal ultrasound where that's a mandatory part of the billing. We picked a retroperitoneal ultrasound, same thing, and an aortic ultrasound. So we didn't end up including renal duplexes, but ultimately I would think that CKD patients have a lot of contact with the nephrologist, are rather high touch, high volume care patients, and that is probably a hidden confounder in the effect of chronic kidney disease.
That was a very relevant paper and very interesting. And from the Central Valley of California, where the stroke belt is, and just down from Stanford, in addition to the 1-minute quick carotid scan for detection of asymptomatic carotid stenosis, we also sometimes would switch from a 7.5 to a 3.5 probe and scan the abdominal aorta. And other times we would use a single lead EKG and auto blood pressure determination for the other two immediate causes of stroke. And at other times we would scan over the common femoral artery, which if there's disease there has a very high correlation, as Loma Linda showed, with coronary artery disease and can be the trigger for metabolic and coronary artery evaluation. So the question is, do you ever do multiple screenings at Stanford? And if you don't, would you like to?
That's a really good question. I think our sort of screening pathway is sort of informed by concurrent disease, but not just concurrent disease itself. So for example, obviously a patient with a popliteal aneurysm, screening them for AAA is highly recommended because of the high concordance of this disease. But we tend to view it more as someone with a carotid atherosclerotic disease necessarily doesn't get elected for AAA screening unless they meet the federal guidelines of being an ever smoker age 65 to 75. As you can imagine, that concordance is high. The Venn diagram is quite close. So I think there's a lot of concordant screening that does happen in our practice as a purpose of just being a center for comprehensive vascular care.
We have a little more freedom to do what we wanted to do.
More cases.
Excellent talk, and I really applaud you for using the market scan database for answering these questions, because I think it's a really very robust data set. One part about market scan, though, it allows us to look at all the forms of private insurers that are covering screening, but within market scan there's also Medicare data. So I was wondering if you guys looked at specifically those that had Medicare Advantage plans. that would, you know, specifically screen for this and, you know, particularly those that were, you know, smokers, to see if that was like a different subgroup, you know, within your analysis.
Thank you for that question. So as you mentioned, all these patients were smokers with evidence on ICD or CPT. I also took patients who are on smoking cessation medication as an indication of that phenotype. We actually, the majority of patients in this cohort, because they are 65 to 75, have Medicare Advantage and with a private insurer as their supplier. So that's about 80% of the cohort. There's a small minority who went from age 65 to 75 without taking advantage of that. But I just think nowadays the mechanisms are so good to enroll patients at 65 into this. I was somewhat expecting a bump at most. I was a little surprised by a result that patients got screened later in life because classically you have this entry to Medicare prevention's early first prevention visit during the study time where you would be indicated to do these kinds of screenings, but that didn't really bear out. So we have upcoming studies using difference in difference analyses to look at sort of when a patient's getting screened and, you know, who are the patient subpopulations we're missing. And Truven does, or MarketScan does have the granularity to provide more insight to that.
That's Dr. Berman.
Congratulations on a nice presentation. Question I don't know the answer to, but I think it's important in this context, and maybe you should try and find out, include in your paper, what's the impact of private screening programs like Lifeline screening or similar programs that are around communities that patients are getting screened, paying out of pocket? Do we know what the impact they have on screening across the country for aneurysms is?
Thank you for that question. It'd be very interesting to do a study on some of these like population level outreach programs. It would require quite a lot of granularity about when these programs started, zip codes that are relevant. I think the best way to do that would almost to have a control population of patients that are very similar who are not in those screening regions, and then have an area of patients with screening regions. But I myself would love to be more familiarized with sort of the heterogeneous uptake of sort of private screeners.
Yes.
Thank you for your presentation. Obviously, the implication here is that we're doing a bad job of screening as a society for AAA. And the question is, who should take on that responsibility? Would you advocate for public health departments just to take on that responsibility, or the insurers, these like Medicare Advantage programs, they should have nurse managers that, you know, actively screen these patients? What do you think is a solution to decrease that failure?
Thank you for that question. I think the lovely part about that is that we don't have to reinvent the wheel. Compliance for screening for breast cancer with mammography or colonoscopy for colon cancer far outstrips our level of accuracy rate. And we know that's based on multidisciplinary care with federal incentives, including more robust incentivization and reimbursement strategies for screening. Additionally, there are different types of physicians who are involved in this, right? As vascular surgeons, we sort of take the end care of this, but higher primary care awareness, family medicine awareness, integration into smoking cessation clinics about who should be screened. I think these are all opportunities to better capture this patient population. Ultimately, I think the answer is that everyone needs to be a little more involved, but there are also, you know, best practices from other guideline implementation efforts that show that it's not really just integrated care systems that can do this well.
That comment about the fact that we're near the end, looking for patients that are already being diagnosed.
And Dr. Kang, our last question for this session.
Thank you for your talk. I actually really loved it. But, you know, I just want to point out that you're actually trying to answer the next question of the next frontier, which is taking seemingly unrelated data sets, right, and heterogeneous types of metrics and putting them together. Because that's the next step, is how do we actually streamline these processes to identify the bad actors? And there are currently models in the trauma data world and also in radiology data world that's looking at using AI platforms, machine learning platforms, where they're taking all these multivariable, multidimensional factors and trying to figure out which ones will benefit most from, let's say, intervention early, or which ones in 5 years are going to be the ones that are going to be the bad actor. So I think it's really important work, and I think it's something that I hope you continue, because that's actually really what a lot of people are asking, is taking what seemingly looks like big data and unrelated big data and trying to pinpoint a way where we can streamline patient access, right? So congratulations. Thanks so much.
I do
Sounds
think
like a
there's,
collaboration with Loma
yeah.
Linda and Stanford in the future. Thank you very much.
All the data. Thank
Yes.
you.
I'd like to bring up Felipe Pavariano, Dr. Felipe Pavariano from UT Southwestern. In presentation, the effects of pre-stenting target vessels on outcomes after fenestrated branch endovascular aortic aneurysm repair.
Everybody. I want to thank the Western Vascular Society for the opportunity to present. These are our disclosures, and some devices are investigational and not FDA approved. So in 2020, this study already reported the effects of preoperative visceral artery stenosis in fenestrated and branched endovascular repair, showing higher target vessel instability for preoperative stenotic vessels, and also lower mid and long-term survival for these patients. We know that adverse features in the anatomy of the patient may hamper the target vessel incorporation, and also even may prolong the operative time. So in order to avoid these features, these specific target vessels were pre-stented in a staged procedure, and the outcomes were assessed. So a single center study, a retrospective study with prospective database, 304 patients underwent fenestrated branched endovascular repair over 7 years, using custom-made devices or off-the-shelf devices as part of physician-sponsored investigational device exemption. And both groups were created and assessed the primary patency, target vessel instability defined as branch-related events requiring reintervention, and the operative time. Among 304 patients, 70 patients had at least one stenotic target vessel, and from those 27 patients underwent a staged procedure with pre-stenting. There were 33 vessels, 3 celiacs, 2 SMAs, and 28 renals. And those target vessels were compared with the ones that were not pre-stented, but not necessarily with a stenotic vessel. The operative time was similar between both groups, with no significance, and there was a trend of lower primary patency for the pre-stenting group, which might be explained by the vessel prior disease. However, a higher rate of freedom from target vessel instability was seen in the pre-stenting group. So in conclusion, I staged target vessel pre-stenting before the fenestrated branched endovascular repair does not affect the primary patency or freedom from target vessel instability. And patients with prior target vessel stenosis, dissections, or other adverse features may benefit from staged pre-stenting. Thank you.
Paper's open for a quick discussion. Yes, Dr. Murray.
Steve Murray from Spokane. I'm curious, I know you didn't do this in a prospective randomized fashion, but there had to be obviously some bias towards pre-stenting versus not pre-stenting. My assumption is that in the face of more severe stenotic disease, you would find it easier to pre-stent and therefore access the target vessel at the time of the FEVAR. Is that a safe assumption?
Yeah, that's a limitation. I agree with you, sir. And this is not a routinely, I mean, since maybe 3 years from now, we have started doing more routinely this pre-stenting. But before, some few patients had undergone this pre-stenting, staged pre-stenting.
Okay, thank you.
Dr. Sweet.
Thanks for your presentation. I kind of moved away from doing this. We almost never do it anymore. And I think
The real trick in this is deciding who you should treat and who you shouldn't ahead of time. And unfortunately, those data might be a lot more helpful in terms of helping other providers understand how to make that decision. And I guess I would just caution in leaving with the conclusion that it's inconsequential when really the issue is how do you decide who to do this for? And Dr. Murray was alluding that, but the size of the aortic flow channel matters a lot. The degree of stenosis, there are multiple anatomic factors, not just yes or no stenosis. So I don't know if you have any other insight into that in terms of how the team decides who to treat. But I think those sorts of insights would be super helpful for the audience. Thanks.
Thank you for your question. I agree also. I mean, for the stenotic vessels, we use it more than 50% of stenosis, but the preference of the operator preference was the reason that the vessel was pre-stented or not, and thinking which vessel could hamper the operative time or, have some issues during the index procedure.
Dr. Gaspar? Thanks. Great presentation, Warren Gaspar from UCSF. And I sort of echo what Dr. Sweet had mentioned. I think this is great. And certainly it only takes one case where you can't get into a target vessel to really think about doing the pre-stenting approach, but you've got to be a little cautious and not have it hang out into the aorta or the flow channel. But sort of along those same lines, did you look at all at the size of the vessels? I mean, we know that the diameter, for instance, of a renal artery is affected, the outcomes of that branch are going to be affected by its size. So anything less than 5 is compromised. So just in terms of your target vessel instability, did you look at size of the target artery or also branch versus fenestrated approach?
Thank you. And this is a good point that we can address in the paper. And yeah, I think maybe we can find something more interesting with these outcomes. Thank you.
Dr. Hahn?
Thank you for the nice presentation. We still use pre-stenting, but the indications that I sort of feel like we have gone to is, as Dr. Gaspar mentioned, when you're not sure whether you can get into the vessel, if that vessel can be incorporated. But noticing that all of your devices are CMD and the manufacturing shipping time that takes for the CMD device to come back, how did you time the pre-stenting to the actual implant? And do you worry about vessel patency? Do you worry about disrupting the aneurysm if the aneurysm is, the vessels are actually coming off the aneurysmal segment?
Thank you for your question, sir. We didn't address the time, but normally we use maybe around 2 or 3 months before the index procedure, since we have to wait for the custom-made device to arrive. So as soon as the patient comes to the clinic, we see that we might have a problem with the incorporation. So we think that we might do a stage procedure and then wait for the device to arrive and then just go for it. Thank you.
All right, last question.
Just a comment, since I'm on this paper, regarding the decision-making for pre-stenting these target vessels. I think when we have small lumen aortas with stenotic vessels, I personally avoid pre-stenting those, because if you have any protrusion of the stent into the lumen, then you can make your procedure more difficult. That being said, the larger the aneurysm and the more severe the stenosis, especially of the renal arteries, it's nicer to pre-stent it because it gives you a nice target to aim for. But if you have a large aneurysm, you have a lot of space to traverse, and you've got a severely stenotic vessel, it can be sometimes very challenging to cannulate that vessel. And if it's been pre-stented, then it's very easy to see where to go. I think dissections also, if we're going to do dissections, sometimes we'll pre-stent them if we think it's going to make it easier. But certainly not every vessel that has a stenosis needs to be stented. I don't think that's the point of the presentation. It's just that pre-stenting target vessels doesn't necessarily compromise your ability to do a FEVAR.
Thank you. Thank you very much.
Thank you.
Right. Final paper for the morning is reinterventions after physician-modified endovascular grafts for treatment of juxtarenal aortic aneurysms are non-detrimental, tongue-tied this morning, to long-term survival. Ayomi Tachida from the University of Washington. And this is also another candidate for the High President Award.
My name is Ayumi Tachida, and I'm a second-year medical student at the University of Washington. Thank you to the Society and my mentors for the privilege of presenting this work today. Yeah, our disclosures are listed here. Previous studies in fenestrated and branched endovascular aneurysm repair have shown that reinterventions are common and affect up to 40% of patients in 5 years of follow-up. These are typically non-detrimental and may even be beneficial to survival. However, in physician-modified endografts, which are in the United States, are typically performed off-label and outside of IDE, opportunities to look at reinterventions in the long term have been limited. Therefore, our aims for the study were twofold. Firstly, to describe all reinterventions in granular detail after PMEG in a single center physician-sponsored IDE trial. And secondly, to examine the association between reintervention and long-term survival overall and according to the type and timing of reintervention. We studied all patients undergoing PMEG at Harborview Medical Center from 2011 to 2021. Data were acquired prospectively. And all procedures requiring a return to the operating room were noted as reinterventions and classified as follows: open or percutaneous, major or minor in accordance with Society for Vascular Surgery standards, high or low magnitude based on the physiological impact of the indication or the reintervention itself, and early or late timing. All data were documented using standardized reporting forms. We assessed demographics, comorbidities, procedural and anatomic details, and outcomes. We also completed time to event analysis for both death and reintervention rates. We had 50 patients undergoing reintervention and 120 patients who did not undergo reintervention within the 5 years of follow-up. These groups did not differ in age, sex, comorbidities, or preoperative medications. They also did not differ in indication for PMEG, presentation, and urgency of repair. Anatomic details were also similar across groups. Procedural details were also assessed. There was 7 more minutes of fluoroscopy time on average in the reinterventions group compared to the patients who did not undergo reintervention. Our perioperative mortality was very low at 4%, and this did not differ across groups. Our technical success rates were very high across both groups. Overall outcomes did not differ between the groups. Looking at freedom from reintervention over 5 years, at 1 year, freedom from reintervention was 84%. And at 5 years, freedom from reintervention was 60%. The most common indication for reintervention was endoleak, representing 40% of reinterventions. Secondly, the second most common indication for reintervention was target vessel. And the third most common was pseudoaneurysm at 9%. Reinterventions for catastrophic events such as visceral ischemia or ruptured abdominal aortic aneurysm was rare. 80% of reinterventions were percutaneous. These represented 80% of all reinterventions. The most common percutaneous reintervention was renal stenting, representing 26% of all reinterventions. And secondly, common iliac stenting, representing 13% of reinterventions. Open reinterventions represented 20% of reinterventions, and the most common reintervention type was access site repair. We looked at survival by reintervention status, looking at all reinterventions compared to patients who underwent no reintervention. There was no difference in survival over 5 years. Next, we looked at survival by reintervention access type. There is no difference between patients who underwent no reintervention, patients who underwent percutaneous reintervention in green, and patients who underwent open reintervention in blue. We also looked at survival by magnitude of reintervention. Patients who underwent no reintervention, patients who underwent minor reintervention, and patients who underwent major reintervention did not differ in survival. We also looked at survival by reintervention timing, which was significant. Interestingly, patients who had later reintervention had the highest survival rate, followed by patients who had no reintervention, and patients who had early reintervention had the worst survival rate. Importantly, these findings persisted after adjusting for age, sex, and comorbidities, with early reintervention associated with worse mortality. And also of note, reintervention overall was not associated with decreased survival in adjusted analyses as well. Also want to note that most reinterventions were minor and low magnitude. In conclusion, reinterventions following PMEG are common. They are most often minor and percutaneous procedures. And this is an important data set in that we were able to follow PMEGs over the long term with a rigorous follow-up protocol. Taken together with prior literature, a reasonable rate of reintervention may be a marker of adequate long-term follow-up and a critical component to the treatment of complex aneurysmal disease. Of note, reinterventions after PMEG overall are non-detrimental to survival. However, early reinterventions do seem to carry an increased risk of mortality, which likely reflects a complication rather than the management of chronic disease. Thank you for your attention, and I welcome any questions.
The paper is up for discussion by Dr. Linda Riley from UC San Francisco.
First of all, congratulations, Ayumi, very nicely presented. Obviously, this is complex work and excellent job for a second-year medical student. So the authors present this series of data to provide additional information about the impact of reintervention on the treatment of patients who underwent only juxtarenal aneurysm repair in this series and only patients with physician-modified endografts. As one would expect, when reinterventions are usually percutaneous and with low physiologic impact, there was no impact on survival and overall outcome. I say this observation is expected because it is the same as the conclusions of other published series of reconstructions after endovascular treatment of complex aortic aneurysm repair, including 2 series which did have a fair number of patients with PMEGs, one with 2/3 of the patients with PMEGs and one with 3/4. So we have prior experience to predict this result. And besides that, I like your conclusions because they conform to my biases. In any event, ignoring for now the potential issues of cost of reintervention and of the required unending surveillance, which somebody will probably ask you about, I have 4 questions. First of all, since the decision to reintervene is not protocol driven, can we be certain that there was no selection bias in who got a reintervention and who did not that might have impacted your outcomes? Secondly, this clinical experience, as most of these, was accumulated over about a decade. So during this time, has the UW group changed its approach to reintervention in any way that also might have had an impact on the observations? Given that, third question, given that most of the interventions are on branches, not only in your series, but in other people's, and that most of the target branches are the renal arteries, has your group identified anything that might help us with the vexatious issue of durability of the renal artery interventions. And finally, I note that your incidence of single reintervention is fairly low, meaning that most of the patients had to have more than one reintervention at some point during follow-up. And that's in comparison to the reports of series with non-PMEG patients, where the incidence of single reintervention is about 80%, 75, 80% as compared to your roughly 50%. And also the previously published series that had PMEG patients had about 60% or so of single vessel reinterventions. So is this difference between reintervention rate between PMEG patients and non, is this an issue of completeness of follow-up, of the length of follow-up, the type of follow-up, or is it possibly a suggestion that there actually is a difference between PMEG patients and non-PMEG patients that we might not have been able to tease out yet, given the relatively small numbers of patients in the series that are published? So again, thank you for the opportunity to discuss this, and thanks for sending me your paper well in advance.
Thank you so much, Dr. Riley, for your close reading of our manuscript and also your very thoughtful questions. With regards to your first question regarding selection bias, I think that selection bias is a really important consideration in this non-randomized study. And we tried to mitigate selection bias with regards to who undergoes reintervention by adhering to evidence-based practice in undertaking reintervention. For example, for endoleaks, which was our most common indication for reintervention, type 1 and 3 endoleaks were intervened upon right away as soon as possible, and type 2 endoleaks were only re-intervened upon in the context of sac enlargement. And with regards to your second question around any changes in our follow-up or in our reinterventions across the 10 years of our IDE, our frequency and indications for reintervention have been pretty steady across all 10 years. With regards to your third question about reinterventions in target vessels, we've learned throughout the IDE that it's really critical to ensure adequate flowering and pertusion to prevent type 3 endoleaks. And we also take meticulous time and sizing to ensure that we are using the appropriate stent. However, we know that renal reinterventions remain an Achilles heel and remain a challenge in all branched and fenestrated repairs. And lastly, regarding the different rates of multiple reintervention in other studies compared to ours, it's hard to know why our rates of multiple reinterventions are higher. However, our IDE is 10 years old and more than 10 years old, and we have a mean follow-up time of 33 months, which is quite high compared to other studies. And so this may account for some of the differences. Patients who are at least 10 years out begin to have very similar results in terms of reintervention rates.
Thank you. Dr. Lee.
Thanks, wonderfully presented. Congrats to the group for over a decade of really sort of adding to our knowledge of this. You started to answer the mean follow-up time, which is what I wanted to know. I was hopeful that it would be in the 3 to 5 year range, because I think much like a lot of these series over the years, now that groups have reached over a decade of doing these, I think that number will sort of continue to increase. And per Dr. Bauman's comment earlier, I think as we have more and more of these types of patients that we're following out, I think we do have to be looking at sort of 8, 9, 10, 12, 15 year follow-up in terms of what the problems are. My specific question is patients that have reached kind of 5 years that in a sort of industry-sponsored clinical trial might have less stringent requirements for contrast CT scan. What you guys have done, since most of the reinterventions are renal, if you have good SAC regression, I'm just curious if you have switched to just doing duplex ultrasound after a certain amount of time, or whether from this large experience, you might have some predictors of patients that we could back off on some of contrast radiated CT scan follow-up. Thanks for your presentation.
We are working on thank you for the question. We are working on a study in the same cohort, looking at endoleak rates and reassessing kind of standards for duplex screening and whether we can reduce some of that radiation burden in this cohort. Dr. Zedeval, if you have any other thoughts, I would welcome them.
Sure. Great job, Ayumi. And thanks for your question. I think in regards to the follow-up, we have a number of patients now who have exited the study in all terms, have completed their 5-year follow-up, and we're going to actually be looking into those patients and bringing that data forward in the coming year. That being said, our follow-up interval, even after they exit, has not changed at all. We still do the annual imaging. We have transitioned to using ultrasound. We do renal ultrasounds always to specifically look at those branches. And I think for folks who are worried about or we feel like there's not quite enough detail, we'll use a non-contrast CT in param. But I think the renal ultrasounds have been really helpful, particularly in our lab. They've unfortunately, some of the outside hospitals is not quite as the same caliber, but in general, it's been very reliable for us.
Next question.
So you're a medical student.
That's correct.
Okay, so apply to UC San Diego, okay? You did a really good job, and congratulations to you, to Ben and the group. As always, amazing, outcome and follow-up. So this is more like philosophic and just more of a comment, but I mean, you had about 30 to 40% re-intervention, and we know from the prior data on open perirenal, the re-intervention rate is definitely not even close to 40%. So, I mean, are we always pushing to kind of do more and more open repair, and maybe, be good for the trainee to kind of learn how to do those. And I'm sure Dr. Starn and his group do a lot of open also. And when someone is getting a minimally invasive, physician modified, they're truly high risk for open. But I just want to make a point that this is very, very costly. That 40% of patient by 5 years can have re-intervention. We don't really factor the cost. We know the cost postoperatively might be even in favor of endo, despite spending $80,000 to $90,000 every case because of the extended length of stay in the ICU. But we never really incorporate the long-term re-intervention. So this might be kind of interesting thing to think about for a future study. Great job.
Thank you so much. And thank you for the invitation to apply.
All right, thank you. Thank you, Dr. Cicito. Great session this morning. This is just the start. We still have a session after this, but we'll take a break for about a half hour and resume back at 10:20. Please take the time to visit our exhibitors. They're a key part to the success of our society and the success of this meeting. Thank you, everyone. We'll see you in about half an hour.
Goes like this: the fourth, the fifth, the minor fall, the major lift, the baffled king composing hallelujah, 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 hallelujah. Well, your faith was strong, but you needed proof. You saw her bathing on the roof, her beauty and the moonlight overthrew you. She tied you to her kitchen chair. She broke your throne and cut your hair, and from your lips she drew hallelujah, 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 hallelujah. I've seen this room and I've walked before. Used to live alone before I knew you. But I've seen your flag on the marble arch. Our love is not a victory march. It's a cold and it's a broken hallelujah. 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 Maybe there's a God above, but all I've ever learned from love was how to shoot somebody who outdrew you. It's not a cry that you hear at night. It's not someone who's seen the light. It's a cold and broken hallelujah. 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 Hallelujah.
Have I told you lately that I love you? Have I told you there's no one above you? Fill my heart with gladness, take away my sadness, ease my trouble, that's what you do. All the morning sun and all its glory, reach the day with hope and comfort too. And you fill my life with laughter, you can make it better. Ease my troubles, that's what you do. Brother, love is divine, and the judgment's mine like the sun. At the end of the day, we should give thanks and pray to the one. Say, have I told you lately that I love you? Have I told you there's no one above you? Fill my heart with gladness, Take away my sadness.
Or I'm unmuted.
Ease my troubles, that's what you do. Like the sun. At the end of the day, we will give thanks and pray to the one. Have I told you lately that I love you? Have I told you there's no one above you? Fill my heart with gladness, take away my sadness, ease my trouble, that's what you do. Take away my sadness, fill my life with gladness, ease my trouble, that's what you do. Fill my life with gladness, take away my sadness, ease my trouble, that's what you do.
That's 1, 2, 3. Testing 1, 2, 3. I can't hear you.
I'm so done riding, let me try it again. 'Cause my last time on earth I lived a whole world of sin. I'm so glad that I know more than I knew then. Gonna keep on trying till I reach the highest ground. Teachers, keep on teaching. Preachers, keep on preaching. Words, keep on turning. Doesn't bother me too long. Oh no.
Okay, now you should hear me. Yeah, I can hear you talking now.
Believers, keep on believing. Sleepers, just stop sleeping. Doesn't won't be too long. Oh no. I'm so glad that he let me try again. 'Cause my last time around, I never overstand. I'm so tired that I know more than I do then. Gonna keep on trying till I reach my highest ground.
Okay, can you hear me now, sir?
I can hear you, yes.
Okay,
Can you,
stand by.
can you hear me?
One moment. I just need to make sure we're trying to get you. Stand by one moment, sir.
Okay, just leave it loud. Okay, cool. That's what I thought.
Hold on to me as we go.
Right. Copy that. Okay, thanks. Bye.
As we roll down this unfamiliar road. And although this wave is stringing us along, just know you're not alone. 'Cause I'm gonna make this place your home. Settle down, it'll all be clear. Don't pay no mind to the demons, they fill you with fear. The trouble, it might drag you down. If you get lost, you can always be found. Just know you're not alone. 'Cause I'm gonna make this place your home. Settle down, it'll all be clear. Don't pay no mind to the demons, they fill you with fear. The trouble, it might drag you down. If you get lost, you can always be found. Just know you're not alone. 'Cause I'm gonna make this place your home.
did. I am not the voices in my head. I am not the pieces of the brokenness inside. I am light. 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 I'm not the mistakes that I have made or any of the things that caused me pain. I am not the pieces of the dream I left behind. I am light. 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 Yeah. I am light. I am not the color of my eyes. I am not the skin on the outside. I am not my age. I am not my race. My soul inside is all light. All light. Oh, light. Yeah. Oh, light. I am light. I am light. I am light. I am light. Yeah. I am divinity defined. I am the God on the inside. I am a star, a piece of it all. I am light. Hoping you take that jump and don't feel the fall. Hope when the water rises, you build a wall. Hope when the crowd screams out, screaming your name. Hope if everybody runs, you choose to stay. Hope that you fall in love and it hurts so bad. Hey, the only way you can know, you give it all you had. And I hope that you don't suffer, but take the pain. Hope when the moment comes, you'll say, I did it all. I did it all. I owned every second that this world could give. I saw so many places, the things that I did. Yeah, with every broken bone, I swear I lived. Hope that you spend your days, but they all add up. And when that sun goes down, hope you raise your cup. Oh, I wish that I could witness all your joy and all your pain. But until my moment comes, I'll say, I did it all. I did it all. I owned every second that this world could give. I saw so many places, the things that I did. Yeah, with every broken bone, I swear I lived. I swear I live. Every broken bone, I swear I did it all. I did it all. I owned every second that this world could give. I saw so many places, the things that I did. Yeah, with every broken bone, I swear I live. I swear I live. I know you've been hurt by someone else. I can tell by the way you carry yourself. But if you let me, here's what I'll do. I'll take care of you. I loved and lost the same as you. So you see, I know just what you've been through. And if you let me, here's what I'll do. Oh, I just got to take care of you.
to worry. You don't ever have to cry. Yeah, I see them beside you. So dry your weeping eyes. So, darling, tell me that you'll be true. There's no doubt in my mind. I know what I want to do. And just as sure, one is two. Oh, I got to take care of you. I just got to take care of you. Take care of you. Imagine there's no heaven. Do you think you'll try? Go down below us. Only sky. Imagine all the people living for today. Imagine there's no country. It's hard to do. Nothing to kill.
Check 1, 2. We'll be starting here shortly, folks. Thank you.
All right, let's come back in for this session. Thank you. It gives me great pleasure to introduce my visiting speaker. And unfortunately, due to all kinds of issues, it's going to give us our lecture virtually. I'm sure it will still have the same impact. And he's a spectacular person, spectacular surgeon. I first heard rumblings about the great Dr. Upchurch when he was at the University of Virginia and followed his research and his career. And then when he moved to the University of Florida as the chairman of surgery there, I got a chance to interact more with him. It was kind of fortuitous that we served together on two societies, both the Society of Clinical Vascular Surgery when I worked with him as he was president, and then on the Vascular Surgery Board where he was the chairman of the Vascular Surgery Board for 2 years. And I worked under him there. He's a true inspiration, true leader, true visionary, and been a real big supporter of my career and moves that I make in my career. So I'm very glad to introduce Dr. Upchurch, and he'll be talking to us about the joy of community in vascular surgery. And again, it will be virtual, but he will be available for questions live at the end of the presentation. So hopefully you all enjoy it.
First, let me say how appreciative I am of President Rowe and the Western Vascular for inviting me to join you, even if it is remotely. I apologize for not being at your meeting. I do want to publicly praise Dr. Rowe for his continued leadership in vascular surgery. His leadership on the VSB, as treasurer of the Society for Clinical Vascular Surgery, as president of the Western Vascular, as an associate editor of Rutherford, and now in his division chief role at UCLA, all speak to the important and lasting impact he has on our specialty. Thanks, Vince, for having also the faith in me to say something that may carry meaning to those in the audience. My wife, Nancy, is a voluminous reader of books. You remember those things that are printed on paper? After nearly 30 years of marriage, it dawned on me that we'd really never shared books. Therefore, during COVID, we decided to try and enrich our marriage by exchanging books. I asked her to pick out 5 books that she enjoyed and share them with me so that we could talk about them and have them in common. Incidentally, when I asked my wife to pre-read this talk, she said, "You make me sound like a total downer," based on the book she had given me to read. In all honesty, my wife, Nancy, is the most positive person I know, and my kids are a direct reflection of her positive energy. While she refuted my initial portrayal of the books she shared as they somehow portrayed her in a non-joyful light, I realized that each of these books challenged me to think about finding joy in non-standard communities. It was not lost on me that 2 of the 5 books my wife gave me were about grumpy old men. I'm pretty sure she was trying to tell me something. In the book, A Man Called Ove, the town grump, after losing his wife, is subjected to a young family that moves in across the street and breaks all the rules of the housing project. While Ove himself is a strict rule follower, ultimately, he is taken in by the, quote, foreigners from across the street and learns to love the rule breakers and be loved by the rule breakers. In the story of Arthur True Love, the old man Arthur meets a girl named Maddie in a cemetery when he is visiting his late wife's gravestone. They befriend each other and ultimately form a non-traditional family. All of these books confirm the idea that your community or family is just not who you're related to, but your family can also be those who you work with, your partners, your lab or operating room techs, your fellows and residents. They are your community. All these books have at their core the interdependence of friends and coworkers, even people who you might not typically engage with, providing support and love to those experiencing grief. Since the pandemic, I've heard many healthcare providers, including surgeons, nurses, staff, and trainees, describe the emotional impacts of COVID as leading to long periods of loneliness and depression. Can you imagine being alone, dying of COVID, and how that patient felt when isolated from loved ones for fear of viral transmission? The aforementioned books all have protagonists who find themselves alone, but ultimately find love, friendship, and meaning from the unexpected, namely being forced to find strength through a connection with others. As vascular surgeons, we dedicate ourselves to doing for others, sometimes against incredible odds. Note in this scene from True Grit, Rooster Cogburn, played by John Wayne, is taking on 4 bad guys at once. These 4 bad guys could be aneurysms, carotid disease, venous disease, or PAD. Armed with a scalpel, some wire, some grafts, and even a few stents, we take on some of the most complex pathologies in all of human disease. For this privilege, we should be thankful for our ability to help others heal through surgery. I'd like to suggest that you remember E.B. White, the author of Charlotte's Web, who suggests, by helping others, perhaps I was trying to lift my own life up a trifle. At the beginning of the pandemic, I discovered renewed joy in getting back to the operating room. While I had really busy practices at the University of Virginia and at the University of Michigan, my job as chair requires a fair amount of time away. However, during the early COVID pandemic, with restrictions on travel and in-person meetings, I was confined to Gainesville and was better able to support the vascular surgery team. While some might find it hard to call it a period of, quote, career affirmation, 23 years post-fellowship, I was reminded that I love being in the operating room where the team takes on the responsibility of making someone who has trusted you to treat their disease better. While I remain convinced now more than ever that we as surgeons and vascular surgeons need to actually lead healthcare systems outside of the operating room, the pandemic also served as a welcome reminder that I love to be in the OR, and that being of all my jobs, being a vascular surgeon remains my true north. At present, with all the nursing shortages, people leaving healthcare in droves, et cetera, it might feel like, as the columnist David Brooks suggests, our society has become a conspiracy against joy. In fact, it is easy to think of joy as something that follows success or something you feel when things are going well, but it's actually the opposite. Having joy leads to success. Longitudinal studies of hospital employees, automobile manufacturer workers, college students, and Catholic nuns have all concluded that joy is associated with better performance reviews, higher pay, and greater long-term health and longevity. It is theorized that joy yields these advantages by making us more creative, intellectual, social, and collaborative. Germane to the pandemic, joy might actually boost your immune system. A group of scientists administered a survey to assess emotional states among 334 healthy volunteers who were administered rhinovirus, the virus that causes the common cold, nasal drops, and then were quarantined. After controlling for virus-specific antibody levels prior to inoculation and other demographic factors, there was noted to be a significant dose-responsive relationship between positive emotional positive emotional style or joy and objective signs of having a cold. This suggests that joy even fights the common cold. So, where did you find joy during the pandemic? Many of my cohorting young faculty found joy in actually getting their past due academic work done. Here in this middle picture, you can see one of them writing a K-23 grant with his son in his lap. Others with school-age kids found joy spending more time with their children and learning that their kids are by far smarter than their parents were at a similar age. We learned to Zoom with family members who are remote. Wouldn't it be nice if the new normal involved more regular FaceTiming or Zooming with your elderly parents? I found renewed joy being in the operating room and also with hanging out with my own grown sons during the pandemic. I was reminded that helping others through performing vascular surgery gives real purpose to our lives. Sometime during the last 2.5 years, as we began to emerge from COVID, we all concurrently found ourselves beginning to question, how did the world become so polarized around seemingly everything? Will we ever emerge from this tailspin? Using my own life as a metaphor, I realize that often it is in the struggle that we grow the most, and that the path is far from linear. In his book, Where Do We Go From Here, Chaos or Community, that I read after the most recent SVS, Dr. King stated that the line of progress is never straight. For a period, movement may follow a straight line and then it encounters obstacles and the path bends. Failing to understand that this is a normal process of development may lead some to experience unjustified pessimism and despair. Focusing on the ultimate goal and discovering it is still distant, it may be declared that no progress has been made at all. This, however, was a misrepresentation in 1967 as well as today. To dismiss a series of small successes because it does not usher in a panacea to our problems is to fail to comprehend the process of achieving full victory. It dissolves the confidence born of a partial victory by which new efforts are powered. We as a vascular community need to recognize that small victories are still victories. And rather than reading off a list of what may be wrong with vascular surgery, I thought it might be better for me to suggest that we will only be our very best specialty when we recognize that the ultimate solution lies in our willingness to obey the unenforceable. And namely for me, and I'm sure for many of you in the audience, that is simply to always do the right thing, even if it is the only truth that you know for the patient. As part of my journey to understand why I was feeling so polarized, and maybe we were feeling polarized as a specialty, I turned to the New York Times bestseller, David Brooks, who had written a book entitled The Second Mountain, The Quest for a Moral Life. Mr. Brooks describes the first mountain, happiness, as one which we should all aspire to. Mr. Brooks importantly states that moving to the second mountain doesn't actually mean rejecting the things we achieve on the first mountain, the nice job, the nice homes, the pleasure of a comfortable life. However, Mr. Brooks does suggest that when society is built around self-preoccupation, its members become separated from one another, divided and alienated. It seems presently the world is built more around self-preoccupation, leading to a loss of connectivity, solidarity, and a focus on the common good. It's in moving past the first mountain to the second mountain that we find joy, and specifically joy in community. On the second mountain, one commits to four things: a vocation, a spouse or family, a philosophy or faith, and a community. Brooks defines joy as making a promise to something without expecting. I'm sorry, I'm going to go back and do this one over again. It is in moving past the first mountain to the second mountain that we find joy in community. On the second mountain, one commits to four things: a vocation, a spouse and family, a philosophy or faith, and a community. Brooks defines commitment as a promise to something without expecting a reward, or even expecting that the work you set out to do will be completed during your lifetime. This definition builds on the approach of doing the right thing even when it is unenforceable, and adds another important element: doing the right thing even, and perhaps especially, when nobody is looking. Brooks suggests that we move from a tribe to a community mentality, where a tribe is defined as a group banded together against a common enemy. And often in vascular surgery, that might be, for example, cardiology, as opposed to vascular disease, while a community is a group that cares about the actual well-being of one another. Our only way to get to the second mountain is to actually recenter, refocus, and continue to build a culture that steers people towards relation and community. We, as a vascular surgery community, need renewal. It is about finding an ethos similar to when we all but first became doctors, that puts commitment to the patient at the center of what we do. We rage against vascular disease together as a community. After almost 3 years of being paralyzed and frozen by this pandemic, as suggested some 50 years ago, there is no deficit in human resources presently, only a deficit in human will. To help us all find joy and be a better vascular surgery community, I have 3 suggestions for you. First, be thankful. Acknowledging the good that you already have in your life is the foundation for all abundance, suggests Eckhart Tolle. During the pandemic, I found renewed joy in the opportunity to care for others. As vascular surgeons, you are all real-life heroes who lead amazing teams. By continuing to help others, you're actively defeating your own sense of grief. You are moving from the first to the second mountain every time you perform a life or limb-saving operation. Every time you are kind and offer inspiring words to an undergraduate or medical school. Every time you praise a postdoctoral fellow who has made a new discovery. Express gratitude that we give to vascular surgery community in pennies, but we receive back in dollars. So number one, be thankful. Second, I want to introduce you to a new term, JVUs, or Joy Value Units. This occurs when you go from making something of your day to actually enjoying your day. While this slide on the left of the screen is a bit blurry, I wanted to show you, this is our residents at an axe throwing as part of our wellness program. The Western Vascular, much like the University of Florida, does a fantastic job of celebrating the many accomplishments and differences of its members and adhering to its mission, quote, to celebrate, excuse me, I'm gonna have to say that one over again. Second, I want to introduce you to a new term, JVUs, or Joy Value Units. This occurs when you go from making something your day to enjoying your day. While this picture on the left is indeed a bit blurred, here are our residents out axe throwing as part of a wellness event. The Western Vascular does a fantastic job of celebrating the many accomplishments and difference of its members and adhering to its mission statement, which is to, quote, promote education, advocacy, and leadership in art and science of compassionate vascular health in the Western United States, Canada, and the Pacific Rim, end quote. As the pandemic passes, it is important that everyone, at least momentarily, reflect on some of the amazing and joyful things that are going on in vascular surgery. In order for you individually and the vascular surgery community as a whole to be our best, we need to continue to increase our joy value units as much as we increase our RVUs. And finally, recognize that you're never alone, and it's okay to ask for help as you are part of a vibrant and amazing community and not tribe. This includes both operative help as well as help when your mental health needs are impacted. Whether it be secondary to the pandemic or entirely situational, we in healthcare are subjected to incredible stressors that sometimes we don't even recognize. Always remember, you are never alone. So I'll conclude by restating the 3 suggestions I have for the Western Vascular in seeking joy and community in vascular surgery. First, be thankful. Second, seek joy RVUs as much as you seek relative value units. And third, recognize, importantly, you are never alone and it's okay to ask for help. In closing, as we emerge from this pandemic, let me suggest that you reconnect with a good book. Call a friend you haven't spoken to in a while. Visit a relative you haven't seen in 3 years. Take up a new hobby or go volunteer at a homeless shelter. For me personally, something as simple as finding a book that has heroes just like you, where a normal person overcomes incredible odds to make the world a better place by finding joy and community, is a great place to start. I want to end where I started by thanking President Rowe for allowing me to ruminate for a few minutes on how, through small steps focused on joy and community, we might make vascular surgery a little bit better. Thank you.
Oh, thank you. I believe we're able to, he's going to log in now and accept some live questions. Any questions from the audience initially? I really enjoyed your presentation. Can you hear me okay?
I can hear you fine, Vince. Thanks so much.
Yeah, thank you so much. You know, I would say for the three things that you talked about, the first one really resonated with me. I think at some points in your career, you just get so bogged down with everything that you're doing, you kind of forget to be thankful. And I don't know when we lose that. Do we have more thanks in us as we're traversing through medical school acceptance and residency, or is it now after you bought a better car or I had a better vacation? But I found myself losing it and just focusing too much on things that were somewhat negative. So I just took up the small act of creating a thankful journal. And so I have this little journal book by my bedside, and I get, done with the day. I just kind of open it up and say a couple of things that I'm thankful for. And it kind of resets me for that next day. And it kind of moves my mood from, oh gosh, okay, bad day. Oh, tomorrow I got, into, hey, there was some good in the day and there's some good in the next day. And oftentimes the things that I put down are not patient related. It wasn't, great bypass or great carotid. No, it was just different things that kind of were things that I needed to be thankful for and stop and reset. So I commend you for talking about that. And I think it's very important. I can speak to myself that it really helped me move through times when you're up and down in your career, personal life, and different things. It really helped to reset my mind. So.
Yeah, I do a similar thing where I try to write down 3 things a day. It's sort of, I can't remember who suggested to me that I'm thankful for. And obviously you start with big things like your wife, your parents, your kids, good job, et cetera. And then you'll find yourself, appreciative that a certain fellow showed up to help you with that case, or that you didn't have to do a more complicated operation. So I think it is a good habit to get into. We've just taken on more and more stressors. I did a ruptured AAA the other night, and I didn't recognize a single face in the operating room other than the first-year fellow. And she told me a number of times, this is only my second open AAA. And I was like, please quit saying that. Please quit saying that. But nonetheless, I do agree. At the end of the case, patient did fine. And so, yeah, I think that's part of this whole idea of trying to heal ourselves. The third point that I made about asking for help, I think is a really hard thing for us as surgeons. And I do think that, that sort of seeks to this idea that we're all having these really tough sort of mental health challenges. It's harder to practice these days with all the shortages, both of people as well as things. And it's a little bit taboo to talk about it, in a big forum like this. So I really appreciate you and the Western Vascular giving me the opportunity to at least touch on it, because I do think it's something that's really, really important. And obviously those things are the thankfulness, the joy, and the sort of your own mental state. They're all sort of interlinked, and hopefully I did an okay job of weaving that together for you.
Oh, we have a question from Dr. Misty Humphreys from UC Davis.
Gib, thank you. It was a beautiful talk. I really wanted to get your perspective as a chair, because how do you set expectations for your faculty, especially junior faculty who feel they have to do all the things, be at all the meetings, and yet they cut their time with their family and give up things where they don't have joy, but they believe that their chair expects it. They believe that their chief expects it. How do you talk about this in your group and let people know that it's okay to do things differently?
Misty, that's a great question. Thanks so much. Mike Conti, past President Conti, told me one time, and I don't know whether, but I do believe this to be true, that the first couple of years in practice are actually the most stressful. And I completely agree with him. I think part of that for me as a chair, you asked specifically about that. I think we have this ability to dictate the way your department is made up. So when I finished, and likely when you finished, I felt responsible for being the best surgeon. I had to write an NIH grant. I had to be the best educator. I had to go to all the meetings, et cetera. And so I think part of this a little bit about changing the expectations. And what I really think has happened is, it's we as a division of vascular surgery or as a department, we're actually we have more strength through heterogeneity than we do through homogeneity. So now the way I believe good departments and great divisions are created is we all have to be really good surgeons. I think that's really important. I won't give that one away. But I think then you just pick off one thing. If you're a great educator, you shouldn't be writing NIH grants. If you're writing NIH grants, then you should, it's okay to be a great educator, but it's not necessarily required. One of my partners, Dr. Megan Tracy, she's been promoted to full professor basically on healthcare policy. That was sort of unheard of 10 years ago when she was coming along. So I think part of it is the expectations of the people around you, and good leaders can be defined by taking the heterogeneity of people and their strengths and putting them together to make a really good department or really good division. I think that's, for me, that's the way sort of I like to build.
Oh, Ahmed. Hi, it's Ahmed Abu Zamzam, Dr. Upchurch. Thank you so much for that. I think that, and I want to thank you and I want to thank Dr. Rowe, because I think that it's been generational and that so much of this is giving people the space to actually say stuff that's really affecting their performance at work. This idea that you show up and you do this great surgery and and you're always on, when in fact you're dealing with other things which you feel like you have to keep separate, is something that is really self-defeating. And having an environment in which people can sort of recognize, the joy, right? What brings you joy? If you talk to your partners and find out what really inspires them, what really excites them, and maybe setting things up differently for different people within the division, within the department. And it sounds like you've recognized that. I think as far as tangible things, those specific things that you do, I'm just wondering, in your department, are there specific things that you do that are more kind of mandated that you find that help in developing this community?
Well, that's a great question, and it's really hard to answer. I talked a little bit about separation. Just trying to get people to come back to in-person grand rounds has been really hard, and we have lost some of that sense of community. We have a wellness function before every Florida home football game. You can only imagine what that actually is, but nonetheless, we make that available for some people who want to come and just hang out, and we pay for it, and it's really good. I think a focus on wellness is something so different than when we were growing up. I don't even know if wellness was actually a word. But I do think that, one of the things is, especially in vascular surgery, Fred Weaver has given this talk about us being the policeman of the operating room. And I completely believe that's true. But you got to have enough vascular surgeons to actually be able to make it joyful. We're sort of undervalued or underpaid for all the stuff that we do, whether it's backing up some TAVR procedure because the iliacs are marginal, et cetera. But I do think that, it's really important that leadership, whether it be in your division, in your department, or even at the hospital level, really value what a vascular surgeon does. And I do think also that you have to have a critical size. I think that's really important. For us, when I first got to UVA, we didn't have enough vascular surgeons, and it was really hard. And even though I consider myself a joyful person, and I missed I had kids playing high school football for 6 straight years, and I missed 2 games in 6 years. So part of it is about prioritization. I think maybe that's what I would, that's how I would answer your question. It was important for me to go to those games. And I would take a whole weekend of call just to not be on call a Friday night when my kids are playing. So I think prioritization and prioritizing wellness is really critical.
Gib, I had one more question / comment. Do you think that we're, as a society, as a organization, as a professional body, moving to a point where we accept people to talk about moments where they may need help, or whether it's emotionally, physically, or what have you with family? Are we moving to that point? I know for myself, I've tried to be more open about certain issues, and I think it helps. I still am somewhat reserved about it, but I've tried. I remember the other night, we had a lady transfer in, and the outside urologist had cut across the aorta, cut across the SMA, and then ended up still taking out the left kidney. That was what their proposed operation was. And she got to us, she was paraplegic, she was hypotensive, and I knew she wasn't going to make it. We've seen these catastrophic injuries before. And so I made sure we waited. And she goes, then the resident was like, "What are you waiting for?" I was like, "Well, I want the son to talk to her because this is going to be his last time talking to his mom." And so the son came in and talked, and then we, took the patient down and everything, and we went ahead, and she didn't make it. But at the end of the case, I knew that the fellow that had helped me had an emotional issue from a unexpected loss in their family. And, I just talked to her and said, I just want you to know that this case took a lot out of me emotionally, because it reminded me when, I talked to my parent before they passed away. And I just want you to know that if there's anything, that you feel about this, we can talk about it. And she said, "Thanks," because I got emotional about it as well. And so I wouldn't have opened up like that any other time. I'm not going to, I'm just going to do the case and go home, and whatever happens, happens. But, I just felt the need to open up. Are we at a place now where we can open up about these things and not be chastised, not be considered weak, or not be, looked at as, "Oh boy, what's this guy talking about?" or "What's she talking about?"
Yeah, great question. So first of all, let me call out the SVS Wellness Committee with Dawn Coleman and Mal Sheehan. They're doing an amazing job. Sam Money, as well as others, are also talking about the issues of sort of chronic pain and addiction by vascular surgeons, and how that impacts all of us. I think the tide is, I obviously am an optimist, and I think the tide is changing. My job now, I'm not here trying to build a practice. I'm here to try and help and support. I have 3 or 4 assistant professors in our group, and I spend a lot of time not doing the case, but being there if something goes wrong for our junior faculty. And Tom Huber and Martin Back do the same thing. So I do think that if just in the operating room, that's a classic example. We're actually, it is okay to ask for help, and people are asking for it, and it's actually sort of fun. And I don't, there's obviously at a place like Florida and places where all of you practice, there's more than enough fun to go around. So, I do think that's really important. Before I finish, I needed to thank thank Heather, Travis, and Chris for sort of helping me to do all this. And once again, I'm so shameful almost that I'm not there with you, because I know what you really learn about a regional vascular society is the personality of it. And I've always got this impression that the Western Vascular, maybe it's because you go to Hawaii every 3rd or 4th year, you're actually a bunch of fun-loving, but also really committed vascular surgeons. And I was just looking forward to sort of enriching myself by just hanging out with you. I told somebody, it may have been Fred Weaver, that this year didn't work out, but I noticed that next year it's in Hawaii, and it may be actually easier for me to get to and back from Hawaii than it is Victoria Falls. So if anybody wants to invite me, or maybe I'll submit an abstract, have one of the young people submit an abstract or something. But it's really been a privilege to be a part of your meeting. I completely applaud both you and the Western Vascular Society, and really appreciate the opportunity just to chat with you and share a few thoughts this morning.
Thank you. And we will start our next scientific session with Drs. Jazari and Wu moderating. Thank you.
Thank you, Dr. Rowe. We're going to get the session started. Our first talk is titled Endovascular Initial Revascularization Approach Predicts Lower Rates of Healing and Amputation After Transmetatarsal Amputation. Dr. Clara Gomez Sanchez will be presenting, and it will be discussed by Dr. NeerAnn Yi.
Good morning, and thank you for the opportunity to present our work. Here are our disclosures. Preserving function for patients with advanced pedal tissue loss remains a daunting challenge. And in patients with tissue loss involving multiple toes or the forefoot, transmetatarsal amputation, or TMA, may allow the patient to maintain independent ambulatory function with a well-balanced foot and preservation of a sensate heel. However, successful healing of the TMA can take many months. Additional procedures are often necessary, and there's significant investment of time on the part of the medical team and patient to successfully navigate the recovery process. However, TMAs represent a critical turning point between limb salvage and major amputation, which has significant implications for mortality and functional outcomes. Increasing age and comorbidities, especially PAD, have been previously shown to increase the risk of TMA failure. And in patients with CLTI, it is important to optimize perfusion to give the patient the best chance of healing. However, optimal strategies for the revascularization is unclear. The primary goal of this study was to evaluate the outcomes of TMA across a multi-institutional academic health system with a focus on patients with PAD and CLTI. We hypothesize that CLTI patients will have better healing and functional TMA outcomes with an index open or hybrid revascularization approach as compared with endovascular. We performed a retrospective review of all consecutive patients who underwent TMA from 2008 through 2020 at 3 affiliated centers of a multi-institutional academic vascular surgery practice. The SBS Lower Extremity Threatened Limb Classification System, or WIFI, was used to classify preoperative limbs at the time of TMA. And any patient with an angiogram demonstrating native vascular anatomy within 6 months of the TMA was graded using the SBS Global Limb Anatomic Staging System, or GLASS. Our primary outcomes of interest were TMA healing during the study and community-level ambulation. Our secondary outcomes were TMA healed at the end of follow-up, any degree of ambulation, which includes the ability to independently transfer, major amputation, and survival. 346 TMAs were performed in 318 patients over the time period, with a median follow-up of about 2.5 years. Of the total cohort, 209 patients had PAD, and this table demonstrates descriptive statistics of the PAD and non-PAD populations. The PAD patients were older and had significantly higher incidence of major medical comorbidities, including CAD and CHF, chronic kidney disease, and end-stage renal disease on dialysis, and prior stroke. Almost all patients had diabetes, about 84%. Full Wi-Fi staging was available in 216 limbs, and angiograms were available for glass scoring in 201 limbs. The largest group of patients had Wi-Fi stage 4 limbs with glass stage 3 anatomy, indicating a cohort with very advanced disease. Revascularization was performed in 185 limbs. Exclusively endovascular procedures were performed in 102. About half the patients treated with endovascular therapies underwent interventions at multiple levels during this index procedure. As you can see, a large majority of patients underwent infrainguinal interventions, and specifically infrapopliteal interventions were performed in about 2/3 of the endovascular-only group. Exclusively open procedures were performed in 74 patients, and about 5% had a hybrid approach. Here again, a majority of patients underwent infrainguinal interventions with bypasses to below-knee targets performed in 3/4 of the open group and below-knee interventions in 22% of the hybrid group. Single segment saphenous vein was used in 56% of the cohort, but overall 71% of infrainguinal bypasses were performed using some sort of autologous conduit. 25% underwent bypass using cryovein, and only 3 patients in our series had bypass with prosthetic. This table demonstrates selected patient demographics and baseline limb characteristics of the revascularized patients by approach. There was no significant difference in age or major medical comorbidities. More patients with GLASS score 3 underwent open and hybrid approaches as compared to those with less severe anatomic distribution of disease. but limb severity did not differ between the cohorts. The primary outcome for healing, TMA healed at any point, was significantly more likely in patients who underwent open approach to revascularization at 76 versus 55%. And similarly, open patients were more likely to remain healed at the end of the study follow-up. Patients with infrapopliteal interventions were more likely to heal with open approach. Overall, 23.8% of the revascularized patients underwent major amputation during their follow-up period, with no significant difference between the cohorts. However, BKA was significantly more likely in the endo group, and AKA was significantly more likely in the open group. As far as our primary outcome for function, which was community level ambulation, it was more likely achieved in patients who underwent open revascularization at 57% versus 34%. When including patients who were only ambulatory to the extent of transferring, there was still a significantly higher rate in the open cohort. When stratifying patients by GLASS score, patients with more severe disease or GLASS stage 3 were significantly more likely to heal with open revascularization versus endovascular. On univariate analysis, looking at factors associated with TMA healing, active smoking, end-stage renal disease requiring dialysis, severe tibial disease with infrapopliteal GLASS score of 4, and revascularization approach were significant predictors of healing. On multivariable logistic regression, however, only the choice of revascularization technique significantly predicted TMA healing, with an almost threefold better odds of healing for patients treated with open revascularization. On univariate analysis of factors impacting community-level ambulation, female gender, COPD, stroke, and choice of revascularization approach were significantly associated with ambulation. Multivariable analysis identified COPD as a significant negative predictor and open revascularization as a significant positive predictor for community ambulation following TMA. And in looking at survival between the two groups, at 3 years, there was no significant difference in survival rate between the endo and open groups. We performed a competing risk model for major amputation after TMA in revascularized patients using death as a competing risk, but there was no significant difference in the cohorts. Due to the retrospective nature of this study, there may be significant selection bias that limits the applicability of these results. Preoperative ambulatory status was not collected in a standardized fashion, given many patients had prior amputations and varying restrictions on their weight bearing at the time of TMA. And the decision of which procedures to perform was selected by individual surgeons. Many of the patients had incompressible ankle vessels and did not have toes available for post-revascularization hemodynamic monitoring. So our ability to analyze the hemodynamic results of these revascularization procedures was limited. Future studies using pedal acceleration time, or TCPO2, may be helpful to explore why our open cohort had better healing in this study. In conclusion, TMAs can be challenging to heal and are often needed in patients with numerous comorbidities, as well as very advanced disease. However, patients may gain significant benefit from their TMA, and indeed in our cohort, more than 70% maintained some ability to ambulate, and 56% were able to maintain independent community-level ambulation. In our cohort, open approaches to revascularization had improved healing and, importantly, improved functional outcomes with ambulation, and this was especially true in patients with more distal distribution of disease. Future work is needed to explore the hemodynamic responses of the various interventions to help further refine our optimal revascularization strategies in CLTI patients needing TMAs. Thank you for your attention, and I'll take any questions.
That's our angle.
Good morning. How are you? Thank you, Dr. Gomez Sanchez, for sending me the paper well in advance. It's a beautifully written paper, and I look forward to getting it published and, or you guys getting it published and me reading it. So thank you to the Western Vascular Society and its program committee for being kind enough to invite me to discuss this paper from UCSF on a very interesting topic indeed. This extensive analysis labors to actually determine whether, based on their experience, open revascularization and endovascular revascularization have equivalent or disparate outcomes on the ability to heal a transmetatarsal amputation in the setting of PAD. This is essentially a review of, as you heard, 346 TMAs in 318 patients, but 209 of these were patients with PAD. And you heard the data over how many were treated with endovascular means and how many with surgical bypass. And this is over 12 years at 3 affiliated centers with very experienced vascular surgeons. So the conclusion, with the attendant limitations for a retrospective analysis, with understandably somewhat incomplete data is yes. Open revascularization is better at allowing healing of a TMA than endovascular therapy. It's tempting to endorse this conclusion a la Dr. Riley because it happens to agree with my own view. But as with any such temptation to rush lovingly into the arms of an inviting, comforting worldview which comports with our own, it's important to pause, question, and then rush into the loving arms of that conclusion which agrees with your own. So I have about 23 questions.
Great.
Just six. So number one, 49% of these 201 limbs had class 3 disease. The open had 73% and 41% in the endo. How many of these open category patients had undergone prior endovascular therapy for the same clinical problem? Question. Yeah, go ahead. We can go one by one.
Finish questions.
All right. Question 2, patients were classified as having undergone revascularization of the procedure was within the prior 6 months or within 1 month after the TMA. That's a broad calendar. So do you have any data on like a histogram of month 6, month 5, month 4? And the reason I ask that is it's conceivable that somebody does an angiogram for a toe, let's say T-6 months, and then it worsens, and at some point it gets to be unsalvageable. Were they restudied? I know this is retrospective, so it's hard to answer. Were they restudied and re-intervened upon, or was it just assumed the angiographic result from that previous intervention was good enough and this is what you got? So it's something to wonder. Post-revascularization hemodynamics, you talked about it, they were only available in 70 limbs. And then you have 11 non-compressible vessels, so now you've got 50 limbs. So in your results, one of the things you state is that there was no statistically significant difference in the mean change in ABI, nor in the toe pressure between the two groups. Now, 2 things come to mind. One is the likelihood of a type 2 error. And the second is, when you did the t-test, was it a paired t-test or a pooled t-test? Because if you just did a pooled, you might miss some important differences between the 2 groups. And then finally, 26% of bypasses were with cryovein. I'm just curious as to what the data is as far as the patency for the cryovein and limb salvage rate, as well as the healing rate. So those are my questions. I enjoyed reading this paper thoroughly, and it should give the reader pause about the strategy employed for patients with a more severe status of critical limb ischemia. It's not clear what the difference is on a physiologic level as far as perfusion to the foot with these different techniques, but there's clearly a difference. And the angiographic appearance is often deceptive because it's uniplanar, it doesn't have volume flow, and the volume of perfusion to the foot with bypass may be dramatically different than just recanalizing a tibial artery. So all in all, a very important analysis. And final question, with this data, have you reached any consensus in your group with patients with Wi-Fi 3-4 and a glass 3 anatomic pattern in terms of which way you go first? Thank you for the privilege of discussing this paper, and I congratulate the authors on a very impressive and methodical analysis of the kind of literature we have to celebrate. Thank you.
Thank you for those comments. So a few things in response. So we had a 6-month window as far as the preceding the TMA of procedures that we included. We did not collect any data before 6 months because we felt the relevance of that to that specific amputation started to become less and less over time. It is our practice that if you have an any intervention more than 30 days and you're coming back to receive some sort of podiatric procedure, we do repeat standard duplex, at least, even if the patient is not able to get ABIs or TBIs for whatever reason. This is part of our multidisciplinary approach, and we do have a pretty well integrated limb salvage team for that reason. So in general, if we did an intervention, 5 months prior to the TMA, that was reevaluated before the TMA was performed, so that if there was a problem with it, we reintervened. And then the index procedure included in the analysis would be that procedure that's assumed to be successful, right before the TMA. Almost every patient, like almost 93%, received their revascularization prior to the TMA. There's a very small portion that did not receive, some sort of revascularization before and then did afterwards. So it's a very small number for that. Our analysis was by treatment received, which assumes that that last procedure was the successful intervention. There are definitely patients who had a bypass as the index procedure who had prior endovascular interventions. But part of our very, close follow-up is if there's any sign that that initial approach is not going to be successful, if the wound isn't progressing, if you didn't see a change on, waveforms on your duplex or your, ABIs, then we do have a pretty early and aggressive reintervention. We certainly do perform endovascular first approaches in patients that seem to have more straightforward anatomy or who are particularly high risk, surgical candidates. But we do, as you said, sort of have a bias at this point that if we know a patient's going to need something like a TMA, which we think is very metabolically demanding to heal, and the patient has a good vein, good distal target, we are pretty aggressive about doing bypasses, earlier. And as you can see, the most complex, the patients with the most complex disease by GLASS score certainly had a bias towards getting a bypass as their index procedure. So that's definitely a bias that we hold as well. I do suspect that we are underpowered to identify a difference in the post-revascularization hemodynamic scoring. I think that when and if we're able to incorporate more hemodynamic measures like TCPO2 or pedal acceleration time into our standardized protocols, that we'll be able to make more comments on why it is that you're getting a better result for these. But I agree, I think we're underpowered to really see a difference in that. And we did use a paired t-test. Sorry. Is that all the questions?
Cool. Well, how about we just go 1, 2, 3? Do you want to start? Thank you.
Hi, thank you. I'm Bianca, a student at Stanford, and I was struck by your slide where the rates of AKA were much higher in the open group, but BKA was much higher in the endo group. And I was wondering if you could explain why that's the case. Is it because, or does that suggest that the endo group might have more distal large artery vascular disease, which might be harder to revascularize in the first place and explain some of your other outcomes? And if so, could potentially using GLASS or like a stratified analysis, stratifying on GLASS score potentially address that?
Yeah, I think that that it may have something to do with the bias of the more severe disease going into the, being biased towards the bypass, and that may explain it. That part of my future direction with this project is going to be looking into that more specifically and trying to really dig into what that difference is, because obviously from a functional outcome, it does matter the patients that get an AKA versus a BKA. But I suspect it's going to be that distribution of more severe anatomy in the bypass group that's going to probably explain that issue.
Hi, Manuel Garcia from Stanford. Congratulations, great presentation and fantastic healing rates. My question is on media artery calcification score. Your group has published on that. Did you look at the patients that did not heal, if they had like a score of 5 or?
Yeah, the PMAC is a pet project of ours we really enjoy. We have a superstar resident currently working on TMA specific outcomes with PMAC scores. So that data is forthcoming.
Okay.
We have room for one more question, sorry.
So my question is about the aggressiveness of your endovascular approach. Like, were you just going after like one tibial target lesion on that pathway beforehand, or were you going after everything? Were you trying to like reestablish a pedal arch feels possible at all? So, or is that not in your data?
Yeah, no, thank you. That kind of granular data, hopefully we'll also be able to get into at some point. So we do standard, a target artery pathway. So we don't typically go after multiple tibial vessels. I don't think we had any patients who had specifically pedal, or I think we had 1 or 2 patients in the whole cohort that had a pedal angioplasty as part of it. I kind of lumped them in with the tibial just because it was such a small number. But we don't do angiosome specific targets, and we don't typically go after more than 1 tibial target. So, I suppose in a patient that you really thought was completely prohibitive, that might be something to consider in the future. Thanks very much.
Our next presentation is entitled Regional Variation of the National Abdominal Aortic Aneurysm Screening Program in the Veterans Health Administration, presented by Dr. Elizabeth George.
Thank you so much.
We thank you for the opportunity to present our work, and we appreciate the ongoing support of the Palo Alto VA. We heard earlier this morning that in 2005, the USPSTF published their first AAA screening recommendations. 2 years later, Congress passed the SAVE Act, offering a one-time screening ultrasound to new eligible patients through its Welcome to Medicare package. It was woefully underutilized in its initial years, with less than 1% of eligible patients screened. That same year, the Veterans Health Administration kicked off its own aortic screening program. Importantly, the screening program was more inclusive, inviting all veterans and their families who met screening criteria to receive an ultrasound, regardless of whether they were new or already part of the system. This is important because there is an extremely high prevalence of tobacco use in the veteran population, at least 3 out of every 10 veterans, which is much higher than the civilian population of about 13%. Given that tobacco use is the strongest risk factor associated with AAA development and progression, it is not surprising then that the prevalence of AAA is higher in the VA versus non-VA healthcare systems. Our prior work found that following the implementation of the VA screening program in 2007, there was an increase in both the number of screening ultrasounds performed and an increase in the absolute number of AAAs diagnosed. On Kaplan-Meier survival analysis, patients with aneurysms found incidentally had the highest mortality. Multivariate Cox regression demonstrated a 55% lower risk of death at 5 years for those who received a screening ultrasound and were diagnosed with a AAA. Since the policy made such an impact, you would hope that the VA screening rates would be near perfect. Thus, the objective of this pilot was to describe and compare geographic utilization trends for screening for AAAs within the VA with the longer-term goal of reducing center-level variation. Using the VA CDW database, we performed a retrospective cohort analysis of veterans who underwent any imaging procedure between 2007 and 2018. Tobacco use was assessed by Health Factors database, as well as a 3-level algorithm, and AAA screening was defined using CPT codes. Screening rates were compared across Veterans Integrated Service Networks, or VISNs, and regional survival estimates were calculated using the aforementioned regression model. The entire cohort was composed of 3.9 million veterans who had some sort of imaging during the study period, and over 320,000 screening ultrasounds were performed. There was an incidence of AAA of 4.8% in the screening ultrasound group and 2.2% in the incidentally identified cohort. There was significant regional variation in AAA screening. Depicted here are VA facilities with more than 1,000 screening ultrasounds performed from 2007 to 2018. 1/5 of the studies were performed at just 5 centers. Even though it says 23 at the far end of the figure, there are in fact 18 VISNs due to some restructuring over the years, but nevertheless, there is significant variability in the absolute number of studies performed. But what about when you consider the denominator? When you factor in the appropriately aged veteran population documented within these VISNs and consider the 30% prevalence of smoking, there is still significant variation in the screening of eligible veterans, ranging widely from 0.5% to 50%. We fall somewhere right in the middle in the Western vascular VISNs on the right side of the figure. The denominator is the key and is in fact the most challenging part of this project. If, for instance, you assume all veterans have smoked at least 100 cigarettes, present company excluded, then the implementation is more on par with guideline recommended screening of low-dose CT for lung cancer within the VA, for example. The greatest number of screening studies were performed in the North Atlantic and the fewest in the continental region. The North Atlantic, Midwest, and Southeast all screened greater than 20% of their eligible veterans. What is curious, though, is that in the multivariate Cox proportional hazards regression models, there is not a universally lower mortality hazard associated with screening ultrasound. In a nationwide analysis of VA patients, despite overall increased adoption longitudinally, the AAA screening program had substantial variation in its utilization across the regions and the VISNs. From what I've described today, we know that screening is associated with improved mortality. Still, we have room for improvement to reduce the center level variation and increase screening in this particularly at high cardiovascular risk population. Future directions include solidifying the denominator, identifying contributors to high and low screening rates within the VISNs to reduce center level variation, as well as examining how AAA diagnosis via screening rather than incidentally identified improves aneurysm-related mortality. Thank you, and I'd be happy to take any questions.
Well, I have a question. So we had a study earlier that showed that the private guys aren't doing it well. Now we have one that shows that the VA is not particularly doing it well. We had one talk that said the nephrologists are actually doing it better than we are screening. So what do we take home from this?
I think there are some examples that we can kind of refer to in terms of, it was referenced earlier, sort of the success of mammography screening and colonoscopy screening. Recently, Ryan Reynolds published his videotaped colonoscopy screening on the internet, and it blew up on social media in terms of, and a lot of GI doctors were thinking, hey, this might be the best thing that ever happened to colon cancer in the past decade. So I think I think we have to kind of reinvent the way that we are approaching this. I think from a patient standpoint, I think it's multi-level. From a patient standpoint, I think more than just education, there is actually a pretty high rate of refusal of screening. Actually, within the VA system, there's a 57% of refusal of low-dose CT scans for lung cancer. So I think some of it is just also really getting kind of more on a qualitative standpoint, really figuring out why are patients refusing screening, not just for AAAs, but for other diseases as well. From a provider standpoint, I think, again, from a societal level, maybe it takes kind of recruiting someone like, I don't know, like Tom Cruise or something to get a AAA screening ultrasound. I don't know if he smoked, but something of that nature to really bring to the forefront of mainstream society the importance of AAA screening. And from a system standpoint, I mean, even healthcare systems like Kaiser, I think, are still at 65 to 70% though, and they really do a great job of kind of following up with their patients. So I think we're going to have to kind of reinvent our approach a little bit.
Dr. Tang.
One of the issues is that sometimes screening ultrasounds are not the only method that patients can get screened for AAA. So, for instance, about 60% of the VAs have a vascular lab that wouldn't be necessarily captured. And it seems like a patient cannot come to the emergency room without getting an abdomen and pelvis CT scan anymore. We have the problem of both over image ordering, because the PCPs get a reminder when their patient is eligible. So I had one recently where the PCP ordered a neuro-iliac duplex and then ordered a CT scan and then also ordered a AAA screening ultrasound. So how did you eliminate the people who had multiple imaging from your cohort in order to actually determine who was adequately imaged?
Great question, Dr. So from our initial cohort creation, we excluded those that had multiple, both the AAA screening as well as the any other sort of abdominal non-screening ultrasound, CT scan, or MRI. Those patients were excluded if they had multiple within the same year. That we the entrance to the cohort was you had a imaging study, and then within 365 days, you then had a diagnosis of AAA within your record, and we had those kind of one-to-one relationships.
We have time for one quick question.
Hi. Thank you for your talk. It was really great. And I think it points to the preponderance of problems, right, of who's owning this problem. And I think the VA, as Dr. Tang alluded to, is very heterogeneous. Like each VISN functions differently. Each VA has different resources. And this has been a topic about AAA screening in the SCSVA committee is, are we going to take it all back in? And how do we have the resources to do that? I think one thing I wanted to ask is when you were going through your data, did you have a way to divide up who was in the ownership depending where in the spectrum you were? And I don't know if this is something you can even do in the way that you analyze the data. For example, in VISN 22, there's a big movement now for all primary care providers to diverse their basically primary care duties to all to subspecialty care. You know, and that's a movement that a lot of VA models are using just because of manpower resource issues. So how do we tackle that? And did you have a chance to kind of figure that out?
I have not had a chance to tackle that yet, but since I'm just starting on faculty at the VA, I hope to take on that duty in the future. But I do think it will require a really individualized approach for each of the visions. As you said, they're structured differently to be able to figure out who's responsible, where the weak links are, and how can we then improve the utilization with each of the different visions. So excellent point.
Thank you.
Thanks.
Our next presenter is from UC Davis, Dr. Catherine DeLosa. She'll be talking about ankle brachial indices and wound classification, teaching to providers as a part of a comprehensive limb salvage program. This will be discussed by Dr. Brian Madison from St. Luke's in Boise.
Thank you to the program committee for the opportunity to present our work. These are our disclosures. Chronic limb-threatening ischemia, or CLTI, affects more than 2 million US patients annually, with one-year amputation and mortality rates as high as 20% and 40% respectively. Optimal management of these patients includes care from a multidisciplinary team. This team will typically consist of a vascular surgeon able to provide revascularization to promote wound healing, an orthopedic surgeon or a podiatrist able to identify and correct mechanical deformities, and a surgeon familiar with advanced practices for tissue coverage and wound closure. However, access to this crucial specialty care is dependent upon appropriate screening, successful diagnosis of disease, and referral to the specialist. Ankle brachial index testing, or ABI testing, has been shown to be associated with decreased rates of amputation and has been shown to facilitate provider referral much earlier than is typically encountered in primary care settings. The Society for Vascular Surgery Global Committee for the Management of Chronic Limb-Threatening Ischemia also recommends early use of ABI testing, as well as the wound infection and foot ischemia, or Wi-Fi criteria, as part of a screening algorithm, with further care recommendations based upon those results. However, even with these recommendations, providers are typically unfamiliar with the appropriate way to screen patients with CLTI, as well as management for their disease. So for instance, while the recommendations from the American Heart Association and the American College of Cardiology agree with those of the Society for Vascular Surgery, other societies, such as the American Academy of Family Physicians, defer to the U.S. Preventative Services Task Force, who unfortunately does not support the use of screening, citing insufficient evidence to attain benefit. ABI testing is a relatively simple process. With appropriate training, evaluation can be completed in less than 5 minutes. However, despite the ease of use, we have found that in primary care settings, assessment of arterial perfusion with an ABI test is performed in only 13% of primary care clinics. So, in an attempt to actively disseminate and increase use of ABI testing and the Wi-Fi criteria, our institution developed a limb salvage teaching platform as part of our comprehensive limb preservation program. This program consists of 2 educational modules, one to teach ABI testing and a second to teach use of the Wi-Fi criteria. We targeted wound care centers, educational programs for nurses and physicians, federally qualified health centers, primary care clinics, and safety net hospitals. Each module consisted of a pre-test, the educational curriculum, with an in-person or online-based video learning module, a post-test, and a voluntary post-completion survey. And all subjects were given access to the teaching platform and the modules free of charge. 180 total modules were completed. 101 participants completed the ABI module, while 79 participants completed the Wi-Fi module. We noted that among participants, 71% were physicians and 29% were non-physicians when they specified their practice. Whenever we were defining non-physician providers, we included nurse practitioners, registered nurses, licensed vocational nurses, as well as wound care technicians. The mean ABI pretest score among all participants was 8.02 points out of a total possible score of 15, and the mean post-test score was 13.16 points. Among 88% of providers who indicated their occupation, we noted that physicians had a lower pretest score on average of 7.92 compared to non-physicians who had a higher pretest score of 8.12 on average. Those in practice longer among non-physician providers, actually had a higher average pretest score compared to physicians who had a lower pretest score. And we noted that non-physician providers at academic medical centers and physician providers in hospital-based practice had the highest scores, while non-physician wound care providers and physicians at academic medical centers had the lowest scores. Both physicians and non-physicians significantly increased their understanding of ABI testing after completing the modules, with an increase of more than 5 points on average between pre and post-test scores. All providers performed similarly on the post-test, and non-physician providers at wound care centers typically scored the highest. We observed similar results in the Wi-Fi module, with all providers increasing their scores on average a minimum of 3 points. And the average score on the post-test was similar among all providers. When assessing questions that were answered most frequently incorrectly, for the ABI module, we noted that providers were unfamiliar with how to correctly hold a Doppler, and they were also unsure about how to calculate an ABI value from pressure measurements. Additionally, providers were also unfamiliar with the next steps in management for patients who were found to have calcified vessels and incompressible ABIs. With regard to the Wi-Fi module, providers were typically unsure when to use the tool and how to correctly stage a wound based on the criteria. And then they were unsure how to interpret the resulting Wi-Fi score. After completion of the modules, participants were asked to complete a survey to identify perceived barriers to use for both tools. More than half, or 53% of physician participants indicated that they would be unlikely to use ABI testing as part of their practice in the future. Among most of the providers, the most frequently identified barrier included a lack of trained personnel or the tools that they needed to complete the module or to complete the evaluation. Other barriers included a limited time for patient evaluation and a lack of financial reimbursement for point of care testing. Among non-physician providers, 52%, however, indicated that they would be likely or extremely likely to use ABI testing as part of their screening algorithm in the future. Again, the most commonly identified barrier was a limited time for patient evaluation among non-physician providers. With regard to the Wi-Fi module, physician and non-physician providers indicated that the most common barriers again included a limited time for patient evaluation, with an additional barrier included a lack of guideline knowledge and non-vascular society support for use of the tool in their practice. So in conclusion, healthcare provider knowledge and use of ABI testing is somewhat limited in primary care settings. This lack of knowledge in combination with barriers to use further decrease adoption of these tools in a primary care setting. Our results indicate that educational modules that are targeted for limb salvage centers can increase this provider's knowledge and close these knowledge gaps. However, significant barriers to use persist and continue to discourage widespread adoption. Ultimately, additional efforts, including more uniform agreement among vascular and non-vascular societies for use of the tools is needed, as well as improved reimbursement for point of care testing to increase adoption and earlier referral to a specialist for limb salvage. Thank you, and we're happy to take any questions.
I would like to thank the Society for the privilege of discussing this very interesting paper. In their paper, Dr. DeLosa and colleagues studied the effects of an education program teaching ankle brachial index testing and use of the wound ischemia foot infection tool for primary providers. The authors cite conflicting professional societal guidelines and a lack of education and training of providers in wound care, which may delay referral to specialists for evaluation and appropriate intervention for limb salvage. They created an educational model that was offered to physicians and non-physicians for wound care centers, nursing, and physician education programs, primary care offices, and federally qualified health centers. The goal of the study was to test these modules and obtain data concerning provider knowledge of ankle brachial index and Wi-Fi testing and determine provider willingness and perceived barriers to implementation of these tools. The education tools seem to be effective as reflected in the fact that post-test scores improved in all participants. Perceived barriers to implementation of the ABI in these settings was lack of trained personnel, limited time for testing, as well as issues with reimbursement. The authors advocate surgeon support for initiatives to improve primary care provider adoption of ideal screening practices. They cite additional barriers, including the lack of reimbursement as discussed for point of care testing. There is also a lack of professional societal support, and that reimbursement by CMS for treatment of wounds is based on the inadequate Wagner assessment of wounds. I wish to congratulate the authors on their efforts of educating providers to screen patients to allow for prompt referral for appropriate intervention for limb salvage in these patients. I commend them on their well-written manuscript, which I received well in advance. I have the following questions. Given the challenges cited regarding implementation of point of care ABI testing and non-diagnostic studies due to incompressible ankle arteries, do you think that it might be more effective to educate providers in obtaining prompt non-invasive studies in an accredited vascular lab? Could an electronic medical record prompt guide providers to order appropriate testing, and could a Wi-Fi calculator also pop up in the chart of patients with these diagnoses? What steps should our vascular societies take to support vascular disease education in medical schools and advanced practice provider training to promote early recognition and specialty referral, given the magnitude of the problem of CLTI? And lastly, how do we get payers and societal guidelines to adopt Wi-Fi? Thank you for your presentation.
Thank you for those excellent questions. With regard to non-invasive studies in place of ABI testing is just an option for primary care providers. There are a couple of things to consider. I think as vascular surgeons, we're often spoiled by having access to an accredited vascular lab, and unfortunately, that is not true for most facilities in the country. So that was actually one of the reasons that we designed this educational module, is to improve screening so that by the time patients are referred to our accredited vascular lab, we have some baseline knowledge that justifies the use of that non-invasive imaging study. And I think that's the other big part of this, is that our prior work has demonstrated that primary care providers don't even perform a vascular exam in 50% of cases. So if that's the case, it would be pretty burdensome on a vascular lab that are typically very busy to be screening patients that have no indication for the screening to be completed in the first place. So I think use of the screening protocol as opposed to non-invasive imaging for screening is more appropriate. With regard to medical record prompt, I think it's an intriguing idea. I know we use it for a lot of other things. Like I know, for instance, Kaiser uses one for AAA screening. I think part of that is that it's not necessarily the same patient population that presents every time with CLTI. We have plenty of patients that are younger that wouldn't meet an age criteria, that have no history of smoking because they have advanced diabetes. It would be very difficult to design a prompt appropriately. I think one way that we could possibly do it would include a prompt in the setting of a new lower extremity wound to just ask providers whether or not they should consider use of any type of screening to evaluate for arterial insufficiency. With regard to disease education in medical schools, I think there's a way to actually kind of kill two birds with one stone. We want primary care providers to be using this technology and this screening protocol. So by having primary care providers adopt this, they're the ones that are also responsible for teaching a lot of our medical students. So we would accomplish better education for all providers going forward. And then as far as payers and societal adoption of the Wi-Fi criteria, whenever we were looking at this, we noted that the Wagner scale is the only one that's recognized by CMS. That scale's been around since 1973, and we've had plenty of research in the vascular world that has demonstrated that Wi-Fi is significantly more effective. Unfortunately, Wi-Fi is a lot younger. It's only been around since 2013. However, we are seeing more adoption by other societies that are validating it, as well as ours, including podiatrists and orthopedic surgeons. So I think the way that we move forward is through continued collaboration with societies outside of our own.
So 1, 2, 3, Dr. Conti, Dr. Sal.
I agree. Actually, in our own practice for our limb salvage program that we use a lot of our telehealth for at UC Davis, we initially tried to incorporate Wi-Fi at the initial site before a referral to a specialist. And ultimately what we found is that it was more effective to have them do ABI testing and then the appropriate resulting imaging, whether it was a duplex or a CTA. And we've kind of moved away from having the primary providers use Wi-Fi. So I do agree with you in practice that it's probably better to have us as a society adopt this tool fully before we move towards having other societies and primary care providers adopt it. And then moving forward, I'm sorry, can you? Oh, yes, sorry. We did not use the app. We actually used a paper form of the Wi-Fi scrying criteria in our actual practice.
Dr. Zhao?
I agree with you that it's definitely a concern. It was actually one of the areas that we noted had the highest number of incorrect answers on the assessment that was done for providers. The education module did, as a result, kind of go towards teaching providers the next step of management for those patients. Other things to consider is that it's part of an entire picture. So when a provider is seeing a patient and they're evaluating them for a lower extremity wound, an ABI testing, an ABI evaluation is just part of their exam. They should also be doing a vascular exam. If they don't have a palpable pulse, it doesn't really matter what the ABI testing is. They should probably also get a referral just to have assessment completed by a specialist. We don't have anything that really validates point of care testing compared to, you know, an accredited vascular lab. I would assume it's much lower, obviously, especially in providers that are less familiar with use of the tools. So I think that's a hurdle that we're still having to face, but kind of like with anything you're looking sensitivity and specificity for, you'd rather get a couple of false positives than have a bunch of false negatives missed, unfortunately.
Thank you. In the interest of keeping us on schedule, we're going to move on to the next presentation. Our next talk is entitled Fiber Optic Real Shape Imaging Using Upper Extremity and Transfemoral Access for Fenestrated Branched Endovascular Aortic Aneurysm Repair, presented by Dr. Felipe Pavarino.
Thank you so much for the opportunity to present, in particularly Dr. Vincent Rowe for sponsoring our presentations. So this is our disclosures, and the device, the graft used to treat the patient is investigational and not FDA approved. So the first in human clinical feasibility study published in 2021 with reported 66 navigation tasks using the FORCE technology with 90.9% of technical success with procedures performed in 2018. And more recently, a multi-center study published in August this year showed 50 patients with 186 catheterizations using FORCE technology, comparing with 15 without the technology, and showed lower radiation exposure. In all of these tasks, the transfemoral axis was used to connect the FORCE guide wire. So the objective of this study is to describe the feasibility of the right brachial artery axis for FORCE technology. So the docking base of FORCE technology was placed on the right side of the patient, different from the usual side that's on the left, as we can see in this image. And after confirming all the target arteries with the IVUS catheter, the AltaTrack guide wire was registered with 2 different projections with 30 degrees in difference, and the descending aorta was cannulated, and the same was done for the infrarenal segment. And after snaring the wire and getting a through and through access that allows the operator to slide the device inside the aorta, the device was then sequentially deployed using fusion guidance. So each target vessel were cannulated using the FORCE technology with minimum radiation exposure for the left renal, the right renal, as well as the contralateral gate using the left femoral common artery as the portal. So after attaching all the bridging stents, and an angiogram confirmed a great position of the bridging stents. And here is demonstrated the radiation levels, the duration of the catheterization, and the fluoroscopy time required to cannulate each target vessel and tasks. So in conclusion, the upper extremity axis and transfemoral axis association for complex endovascular repair is feasible and facilitates target artery catheterization with minimum radiation exposure. But further studies are required, but already in process to support the radiation reduction. Thank you.
This presentation is open for questions from the audience. While people are making their way up to the podium, can you tell us a little bit more about who this technology is available to right now?
So this is a technology that 5 centers in the US and 5 centers in Europe, they are developing. Is already FDA approved, but it's still in development to make sure that, you know, we have some radiation reduction, exposure reduction.
So since it's FDA approved, can anybody use it, or it's not widely available?
So since it's also a clinical trial, it's from a Philips technology. It's not available, like commercially available for using. You need to be registered in a study, physician sponsors, companies study, sponsors study. So yeah, so this is how the technology works with pulses of light.
I think Dr. Malas was first.
Yeah, so good job. Well, to answer your question, Karen, this is like very limited access and is completely controlled by Philips, that they're rolling out certain sites first to kind of see. There's already, your Carlos site is one of them, but the second phase kind of will be also very limited, site selection. But my question to you, I mean, this whole idea is obviously almost no radiation, right?
Yeah.
So in theory, I mean, this is using, fiber optic, and you can essentially do it without any fluoroscopy. So why do you even have any radiation? Is it just the kind of comfort, after you get the wire in to make sure, with the selection and stuff? In theory, you can do it completely without radiation, at least.
Yeah, I agree with you that we can't, but sometimes about some features that we can maybe. That's why the study is rolling. I think it's to find some things that it can be improved. But also we still need to use some fluoroscopy, for example, to deploy the device and all of this. But that's why we also use IVUS and all those kind of things in fusion to make sure that we have a good, how can I say, that the fusion and the IVUS and the force technology will say where exactly the vessel is for me to cannulate the target artery.
And they're limited by the wire length, right?
Exactly, and that's why we are showing this project since it's 110 millimeters working length. So that's why we move it to centimeters. Sorry. So we move it to the right side of the patient to have a working length, so we can use the upper extremity axis to cannulate the vessels.
Good job.
Thank you.
Yeah, can you introduce yourself? I'm sorry.
Oh, sorry. I'm Mirza Beg from UT Southwestern in Dallas. With this technology, you can't eliminate fluoroscopy. Basically, it's a Philips system that works with the Philips Vessel Navigator on their fluoroscopy system. You need fluoroscopy, obviously, to introduce any device that's not based on the fiber optic real shape technology. And the only thing that's based on that is really the wire. So once all it does is allow you to not use fluoroscopy in order to catheterize different vessels. But you need fluoroscopy to introduce the vessel. You need fluoroscopy to deploy the vessel. You need to take some pictures, and the vessel navigator only shows you the preoperative CT scan and where everything is. But once you deploy the graft, you have to get out of the fenestration of the branch. Then you have to take at least a single shot X-ray to overlay the X-ray picture on top of the vessel navigator, and then you can switch to just using the UltraTrack wire. This is just the first generation that's deployed here. I think they have a lot of work left to do to progress this technology. And I think really the future is going to be if they introduce steerable sheets with this technology, then that is going to even further reduce our need for doing fluoroscopy, because you'll really be able to manipulate these wires very well using a steerable sheet as a support for these wires.
I think we have time for a very quick comment from Dr. Lee.
Stay up here. Cost of it, are they willing to share with Siemens, GE, other software companies? What do you see the future really? Is this just one company doing one thing, they're going to hold on to it, or what's the talk?
I doubt they're willing to share. This is, well, I won't say anything, but I don't think they'll share. This does require, basically it's superimposed on top of the vessel navigator system that they have for mapping already, their fusion mapping. The cost of the wires is about $1,200 for a glide wire. The wire itself is not that great, but we've managed to get better at using it. They also make two different catheters, a Bernstein catheter and like a Cobra shaped catheter. Those are also about $1,200 to $1,500. And just like everything else right now, there's a back order of these things, so it's hard to even get them. Despite the fact that there's only like 5 or 6 centers now that are using it in the US, and it's still these wires are back ordered. But yeah, it is very expensive, and we really had to pitch this to the hospital hard in order to get them to purchase it. I think it was almost $600,000 to buy the system before you can, that's on top of the disposable cost of the wires. That's my recollection, is about 600. I'm not 100% sure about that number, but it is expensive. But it's an investment into, I think, the future of where we're going. It's still very, very early.
Thank you.
Thank you.
We have another Bob High paper here to be presented by Terry Holman. All right. Dr. Holman is from University of Utah. She'll be talking about assessment of clinical outcomes following lower extremity bypass and percutaneous revascularization. Should we be following ABIs? We're asking our patients. Dr. Mills will be discussing afterwards.
Hello, my name is Taryn Holman, and I'm a fifth-year MD PhD student at the University of Utah. Thank you for the opportunity to present our work. We have nothing to disclose. PAD affects roughly 8.5 million adults in the United States, many requiring lower extremity revascularization procedures to prevent both limb loss and improve physical function. Ankle brachial index, or ABI measurements, are commonly used to diagnose and monitor PAD progression over time. However, previous studies have shown that ABI-measured blood flow to an extremity does not necessarily correlate to an improvement in patient physical function after surgery. Patient-reported outcome measures, also known as PROs, are validated questionnaires that represent the patient's self-reported health without interpretation from their provider. More specifically, the PROMIS physical function instrument uses an adaptive assessment that includes activities of daily living and produces a quantitative score. Our institution has been collecting patient-reported physical function since 2015 as standard of care using the MEVAL system. These scores are fully integrated into the electronic health record and can be displayed graphically over time. Like this patient shown here, we can be used to show patient changes in terms of PVI and lower extremity bypass. However, it is still unclear how much patient-reported physical function scores are expected to change after revascularization and what factors will impact a patient will reach a clinically meaningful improvement in this physical function. The objective of this study is to examine changes in patient-reported physical function during the year following open and endovascular revascularization for PAD. We identified 284 patients from our VQI institutional database who underwent lower extremity bypass procedures and PVI procedures between January of 2016 and June of 2020. We excluded patients who could not be followed over time and with incompressible vessels defined by an ABI of greater than 1.4. The remaining 179 patients were then stratified based on type of revascularization procedure, which included 100 patients that underwent lower extremity bypass, or LEB, and 79 patients that underwent peripheral vascular interventions, or PVI. We analyzed the association between lower extremity bypass and PVI exposure groups based on changes in patient-reported physical function up to 1 year after surgery. An improvement of 3 or more points in the PROMIS patient-reported physical function score has been previously established as a clinically meaningful change, or MCID, and was used in our analyses to define whether patients had improved their physical function after revascularization. In addition to procedure type, we also performed several sensitivity analyses to evaluate what other factors could impact outcomes after revascularization, including the indication for surgery, comparing claudicants and CLTI patients, and then frail or non-frail using the provider clinical frailty scale. Patient characteristics are shown stratified by revascularization type. The cohorts were fairly comparable, although patients undergoing lower extremity bypass were less likely to be female and have a history of diabetes or dysrhythmia. We first examined the correlation between changes in patient-reported physical function and ABI using Pearson correlation. Our results were consistent with previous studies, which found no correlation at any time point. Next, we looked at changes in ABI measurements stratified by procedure type over 3-month time points within the first year after surgery. While lower extremity bypass patients had significantly lower preoperative ABIs, 79% of all of our patients improved their ABI by 0.15 or a significant improvement at the 3-month follow-up and remained stable over time, irrespective of revascularization type. In comparison, when we examine changes in patient-reported physical function over time, there was an initial improvement in patient-reported physical function at 3 months for PVI, where patients undergoing lower extremity bypass had diminished physical function at 3 months that did not improve above preoperative values until 6 months follow-up time point. At 1-year follow-up, 54% of lower extremity bypass and 47% of our PVI patients had met the 3-point minimally clinical important difference for meaningful change. We also performed sensitivity analyses based on indication for surgery. As would be expected, CLTI patients had significantly lower preoperative ABI values than claudicants, but both groups experienced a significant increase at 3 months postoperatively. There were no significant postoperative differences at 6 or 9 months between these groups. In comparison, patient-reported physical function over time revealed that CLTI patients had a significant initial drop in their physical function at 3 months that rebounded by 6 months, where claudicants on average displayed only a very mild improvement of their patient-reported physical function over time. Overall, 51% of CLTI patients and 50% of claudicants reached and maintained their MCIDs for within 1 year. Finally, we examined the impact of preoperative frailty status on outcomes after revascularization. While frail patients had significantly lower preoperative ABI values, they were comparable with non-frail patients at 3 months, and there were no differences in frailty groups at any other postoperative time point. In comparison, patient-reported physical function revealed significantly lower physical function for frail patients at nearly all time points. At 1 year, 67% of non-frail, but only 29% of preoperatively frail patients reached meaningful improvement in their physical function. We then examined the likelihood of each of these patient groups to reach meaningful change in physical function within the year following surgery using logistic regression models with odds ratios shown on the x-axis. Preoperative frailty was the only significant predictor of meaningful improvement, with frail patients being 80% less likely to reach this MCID, with high discrimination shown by the receiver operating curve area under the curve. We also wanted to see if there were any significant interactions between the groups. And overall, there were no significant interactions between indication for surgery and frailty, or indication for surgery and procedure type, or indication for surgery and frailty. However, preoperative frail patients who underwent lower extremity bypass procedures were then 93% less likely to meet our MCID at 1 year. In summary, ABIs are not strongly correlated with patient-reported physical function. Patient-reported physical function needs to be interpreted in the context of revascularization, indication for surgery, and frailty status. And frailty status is the most predictive measure for 1 year improvement in patient-reported physical function after revascularization. Our primary conclusion is that patient-reported physical function scores can provide a more discriminatory objective measure than ABIs alone to assess longitudinal patient recovery and clinically meaningful improvement in physical function after revascularization for PAD patients. Thank you, and I'll take any questions.
Great presentation, and I thank the Western for the privilege of being the discussant. There's been a long-standing interest in vascular surgery, in particular by members of this society, in examining vascular surgical outcomes from the perspective of a patient, rather than focusing on traditional metrics such as graft patency and change in ABI. For example, patient recovery after intrainguinal bypass for limb salvage was reported by Nikoloff et al. From the late John Porter's group in JVS in 1998. That report emphasized an ideal outcome, and these were surgeon-derived patient outcomes, but consisting of a patent graft, a healed wound, no need for a reoperation, independent living status, and continued ambulation was extremely difficult to achieve in such patients. Only a small fraction, 25% of their patients met these basic criteria. Despite this early attempt at a surgeon-derived PROM, I call them PROMs because it's easier for me to remember, little progress has been made in this area of study over the last 2 decades. This manuscript by Holman and Associates reports a single study from Utah exploring patient-reported outcomes and from a physical standpoint in patients who went either PVI or lower extremity bypass for CLTI and claudication as part of the VQI registry. By 1 year follow-up, 53% of LEB, lower extremity bypass, and 63% of PVI met criteria for clinically meaningful improvement. Although, as you pointed out, it takes longer to recover from an open bypass, so it's an investment. Revascularization type and disease severity were not predictive of the patient meeting minimal clinically significant improvement at 1 year follow-up. However, preoperative frailty status predicted this with excellent discrimination. Non-frail patients were 12.4 times more likely to meet these minimally clinically significant improvements than frail patients at 1 year. The authors focused on the PROMs of physical function, or PRO-PF, and concluded that while both procedures result in immediate and sustained improvements in ABI, it takes multiple months for these to improve after revascularization. That just emphasizes that CLTI and even PAD is a long process, and it's a stepwise process, and revascularization is just the first step. Furthermore, frail patients are less likely to improve their physical function after revascularization, so it's hard to make a frail patient non-frail. So I have the following questions for the authors. What are the best PROMs for PAD patients, and how should they optimally be derived? You used a standardized set, but perhaps we can make these simpler so we can use them in practice. Do they differ by condition? So are they different for CLTI versus claudicants? And could they be used to select among competing therapeutic options? For example, endo versus bypass, or in some frail patients, perhaps benign neglect and wound hospice. Which ones besides physical function are important? And do PROMs differ by region, ethnicity, or culture? And then finally, how would the authors suggest validating which PROMs we should use to incorporate into practice? Thanks again. I think this is a really important focus of our work, and I think thanks for being allowed to discuss it. Thank you.
Thank you, Dr. Mills, for your thoughtful questions and taking the time to review our manuscript. To address your first question, there are 14 specific PROMs or PROs for PAD, specifically the peripheral artery questionnaire, or PAQ, or vascular quality of life, PAD quality of life, have been well published. The PROMIS physical function has been our focus at the University of Utah because it is a generalizable and global metric that we can apply to all patients who walk into our vascular clinic. In addition, our measures are very comparable with high correlation to many of the PAD specific PROMs, and have been crosswalked from these generic measures to create the more specific peripheral artery disease questionnaires. To go back to your initial question, the best PROMs for PAD are going to be sensitive to change, easy to use, and as the Nickloff article that you had noted focuses on physical function and within the context of independence and activities of daily living, which is really crucial for our PAD patients. To address your second question, we would like to acknowledge that there are PROs specific for PAD and CLTI that measure symptom severity and that could be used as decision-making tools. However, we believe that the best or ideal use for the PROMIS physical function instrument should be for not as an intervention tool, but as an outcome measure to help support some of our other commonly used measures like ABI. To address your third question, there are other important patient-reported outcome measures that could be used and applied to our PAD patient population, and that includes depression or mental health, as demonstrated by the rapid fire presentation yesterday, with comorbid depression had an increased 90-day readmission after lower extremity amputation. Other metrics that we have considered for our PAD population include the pain intensity and pain interference measures and engagement in social activities. To address your fourth question, are PROs impacted by region, ethnicity, culture? So we thought this was also a very great question. We just submitted an abstract to the Academic Surgical Congress looking at PRO scores and whether or not they were impacted by ADI, social support, or insurance status. And we ultimately found that there was no impact on any of these measures on our PRO scores, but we're currently looking at other social determinants of health and their impact. Your fifth question we thought was very interesting. There's actually a paper that came out in JVS late last year with senior author Dr. Karen Wu, which held physician focus groups on PROM use and identified
Prom validation and implementation as primary barriers to use and clinical application. So at the University of Utah, in order to decrease these barriers, we have incorporated patient-reported outcomes using the general metrics and that apply to the majority of patients. We also have streamlined data collection by sending patients an email prior to their clinic appointments to allow them to complete their patient-reported outcomes via email prior to their clinic appointment. And these scores are now fully integrated into a module within Epic, which allows our providers to click and see the longitudinal graphically displayed assessment of any of the prompts collected. So our goal is that our research will just highlight the need for pros in clinical practice and help establish guidelines for use and best practice. Thank you.
So we have a few minutes left for questions from the audience. We'll ask the audience to keep your questions brief so we can have as many as possible.
Two really quick ones. One, first of all, congratulations to your group for incorporating this into your standard practice. I hope it's a stimulation to my own group. And we would like to get there too. I think it's critically important. First question is about the MCIDs. Do you think it's actually appropriate to have the same MCID for claudication and CLTI? And where does the data come to support that? The second question is around moving forward from just self-reported PROs to actually functional performance. So what do you think about the incorporation of 6-minute walk testing, either in the clinic setting, we see it with our heart failure colleagues next to us in our clinic every week, or with a digital app to do it at home? As you realize, in, for example, the Clever trial, there was quite a lack of congruence between what patients reported and what they were actually able to do. So just some speculation on that.
Great questions. Thank you so much. So to address your first point about MCIDs, so the minimally clinically important difference, or MCID, that we're using in this study has been established by the NIH and is a validated 3-point change, and that's been shown over various surgical specialties as well. And it does vary based on patient population, with 3 being a pretty conservative measure, but the range is from 2 to 4 points. So that addresses that. And in terms of the association between like the 6-minute walking test and using an app versus our patient-reported outcome measures, they have been shown to be well correlated. So I think that is just then a preference. The thing that we really appreciate about the proms is that they take into account things that the 6-minute walk test wouldn't, things that help our patients stay independent at home, like household chores and activities of daily living that the 6-minute walk test may not incorporate. Like whether or not a patient can raise their arms above their head could be important at home, but not necessarily reflected in a walk test. But thank you.
Dr. Riley?
Really quickly, does duration of frailty have an impact on the outcome, do you know, or the likelihood of getting unfrail?
So that's a great point and great question. I did not examine that. The clinical frailty scale that we're using is just a one-time assessment, or I looked at just the most recent assessment to revascularization for the study, but we do track it over time. Many of our patients do not necessarily improve their frailty status after surgery, but it's definitely something that we can investigate further.
Last question.
Congratulations again. And we've enjoyed collaborating with your group for a number of years on frailty. And that's my main question. We've seen in and I look forward to your group's comments on my paper tomorrow about PROs, but there are patients who actually improve their frailty status as a function of revascularization. I just wondered what your experience has been with that.
So I personally have not been involved with tracking frailty over time. But we have, like the data shown here, we do see improvements in physical function in our patients. So I'm sure revascularization would show that as well. And I look forward to your presentation.
Thank you.
Thank you.
Our final talk in this session is the emotional impact and coping mechanisms following adverse patient events among Canadian vascular surgeons and trainees, presented by Dr. Sally Choi.
As a reminder, please stick after her presentation. Dr. Mills will be giving us an update on the SVS. So please don't all scatter. Thank you.
Hi, everyone. My name is Sally Choi. I'm a third-year vascular surgery resident at the University of British Columbia, and I'm excited to present our work on the emotional impact and coping mechanisms following adverse patient events among Canadian vascular surgeons and trainees. Our team includes Tyler Yan, who's a recent grad, and Dr. Jonathan Miskey and Dr. Jerry Chen. We have no disclosures. So people estimate that adverse events occur in almost 10% of hospital visits, and the indisputable victims in these events are the patients and the families involved. But the people that often get forgotten are the physicians and other healthcare workers involved in the event, who are considered second victims, as they often experience increased rates of burnout, medical errors, and mental illness. In a study that compared 14 different surgical specialties, they found that vascular surgeons were particularly vulnerable to burnout. So they were found to have the second highest rate of burnout, the lowest level of career satisfaction, and the highest rate of suicidal ideation. So keeping this in mind, the objective of our study was to evaluate the coping mechanisms and support resources for Canadian vascular surgeons and trainees following an adverse patient event or a near miss. Our study was a cross-sectional anonymous online survey of the Canadian Society for Vascular Surgery members using their membership database from October to November 2021. So we had a total of 66 surveys completed out of the 233 distributed, yielding a 28% response rate, which is actually similar to similar previous studies. The most common categories of error were operative errors, followed by treatment errors, and then diagnostic errors. And in terms of the etiology of error, the majority were errors of execution, suggesting that even with impeccable planning, a lot of us can be prone to these. The most common coping mechanism after an adverse event was reported to be speaking to and seeking advice from others. So when we asked who the preferred sources of support are after an adverse event, the vast majority of people said peers, followed by senior colleagues, and then family or friends. When they were asked whether they had a mentor or a close colleague who could function as a mentor, 70% responded yes, while 30% said no. And this is in stark contrast to 99% of the respondents saying that they would be willing to support a colleague after an adverse event. And among the 30% that said no, 80% reported that if they had a mentor, they would reach out for support after an adverse event. And 10% said that they would only do so if asked, and only 10% said that they would not use such a resource. So 56% of individuals reported being aware of support services offered by their healthcare organization or local institution. And 50% expressed interest in a peer support program offered by the CSVS. And this number increased to 60% when we looked at the group that reported having no senior colleague or close colleague who could function as a mentor. So we found that adverse patient events and near misses have a serious negative impact on the lives of Canadian vascular surgeons and trainees. And peers and senior colleagues are the most desired sources for support, but this is not universally available. So we need organized efforts to raise awareness in our vascular surgery society on the detrimental effects of adverse events and our mutual need for peer support. Thank you.
Misty Humphreys from UC Davis. Very nice talk. I have a strong interest in this. At the VAM this year, there was a talk that showed that after events like this, women had a higher level of PTSD symptoms than men. So my first question is did you stratify by gender, and did you look at differences in gender? And then my second question is, it leads to this idea of mentor. So somebody trained all of us. Nobody lives in a vacuum. And it's a little interesting to me that these people that are, have these patients or the physicians who said, well, they don't have a mentor. You could call the person who trains you, you could call, anybody. And then from there, you even found that 10%, or I think it was 20% of those that didn't have a mentor, they wouldn't even call anybody anyway. And I find that to be also very interesting. And so I'm curious about that, because what is it, the feeling, what emotions are they having? Is it shame? Is it thinking that they're maybe a bad physician or diving into why they wouldn't call. Because I do think we can call anybody. I have called multiple people in this society several times to ask them about cases or different things like that, and they're not necessarily my mentor. So how do we get people away from this idea that they live in a vacuum and that we need to ask for help?
Yeah, thank you for the questions. I'll break that up into pieces. So the part about whether we looked at gender and how that affected things, unfortunately, to try to keep things anonymous, we didn't collect any demographic data. Maybe it would be more feasible in a bigger country, but our CSVS members is only 233. And because there's not many surgeons and such, it would be very easy to identify people. So we just kept things anonymous. But I've definitely heard that piece about women possibly being more affected. In terms of, I guess, why people don't reach out for help and why people said they don't have mentors, I think it goes two ways. So we weren't asking, have you ever had a mentor in your life? We were asking more, so do you have someone that you would feel comfortable speaking with? And that's why 30% said no. And I think that probably goes both ways, where the person responding in the survey maybe doesn't feel comfortable reaching out, or maybe the kind of environment they're in doesn't really foster that kind of conversation. And then we actually did have some comment sections where people could write down why they would not reach out in that small 10%. And there were a couple of quotes. I don't know if I can find the specific ones, but a lot of the themes were either related to shame or the society being so small that, it would be hard for them to really share what they went through and so on. And I guess the last piece about how can we encourage people to speak up, I think it goes both ways. So it takes a lot of confidence and I think courage to speak up, and also to kind of create that kind of environment for your trainees and also more junior colleagues. Yeah, thank you.
Final comment or question from Dr. Levinson.
Oh, thank you. I'm so glad you addressed the subject. I think it's something we've all been through one time or another, and I haven't heard it addressed at another meeting personally. And I have two comments really. And the one is that personally, I was in the Central Valley of California, and we did a lot of carotid endarterectomies in those days. And our perioperative stroke rate was 0.7%. But when one of those rare ones came along, and the patient was okay, and we'd operate, and then they weren't. And to go home, I'd go home and say, I'm never going to do another carotid endarterectomy. But then you realize that all those other patients for their higher stroke risk, you really helped. And then you get the support from the staff in the operating room and recovery and on the floor and the staff at home, and you go on. But we all love vascular surgery, but I'll just say there are times when it's very hard. And the other comment is that I just love being here in Canada, and I haven't met anybody that has been super friendly. And so I just really almost wish I lived here. You guys are great.
Thank you. You're welcome to come anytime.
Thank you, Dr. Levinson. Thank you.
Maybe Dr. Fujitani, you can make your comment as Dr. Mills makes his way up here.
I don't know if this is working. Can you hear me?
Yes.
So with regard to that, I think that's a very important part of physician well-being. And I know at least at our UC Irvine program, we do have this thing called Code Lavender. And I think a number of institutions around the US have instituted this, so that anytime anyone has had an adverse unexpected event, anyone on the team, because it can affect not only the surgeon, they can affect the support team, the nurses, the techs, et cetera, anesthesiologist, that a code lavender can be called because the effects that can come about are immediate. They're sometimes can be lingering, but there can be some immediate things that can occur, and that brings along some religious, there can be social support, there can be psychiatric support that can bring about and meet with the team on a more immediate basis. And it's called the Code Lavender program. So just wanted to comment on that.
Yeah, thank you for bringing that to our attention. That sounds like a really good idea and something to explore for sure. Thank you.
Well, it's a pleasure to be here. I realize I'm the last person standing between people going to lunch, going to see whales, or playing golf, so I'll try to make it brief. I have 15 minutes, but I'll try to finish in 10 minutes so there's some time for questions, and this is meant to be more of an interaction. I'm not going to read the slides to you. I'm proud of the Western. It's my favorite group. I spent most of my academic career, and no matter how long I work at Baylor, I still will have spent most of my academic career in the West. And it's just beautiful to be here with everybody. So just a little bit. I'm not going to read the slides to you, but I'll highlight them. So there's total membership is a little over 6,000. So we're small, but we're a vigorous group. 37% of members are practicing vascular surgeon. And a group I want to highlight is this 30% who are candidates. So those are recently graduated candidates who have up to 3 years to become full members, 644 trainees, and 414 general surgery residents, some of whom and medical students will become vascular surgeons. And that's the group, at least in my leadership part of the SBS, I want to focus on because they are the future of our specialty. It's not the old guys. Now, if you look at these statistics, they kind of show there's sort of an equal distribution, but if you actually add up the Northeast and what's called the South Atlantic, which includes a lot of Middle Atlantic states, about half the members are actually from the Mid-Atlantic and North Atlantics, but the West is a full 20%. And if you look at the makeup of our strategic board, so I'll get into the executives. The executive board consists of president, president-elect, vice president, secretary, you can see here. And we actually have 2 members from the Western that are on the executive board. We have 2 members on SBS key councils and committees who are from the Western. Your regional representative to the strategic board is Ahmed Abu Zamzam, but I think the Western is fairly represented, which hasn't always been the case. What does the executive board do? So the executive board is this smaller group, and they basically are the governing body of the society. They incorporate and manage and act on all affairs of the society. They're working on amending articles of incorporation and bylaws, and I'll talk to you a little bit about possible changes in the election process. And they report all actions to the strategic board, but it's not a board down policy. It's supposed to be the other way around. So what's supposed to happen and what should happen is that what the society does is driven by the members who communicate that to the strategic board, who then give the executive board things to act on. So we represent you. We're not the top down, we're the bottom up. The strategic board meets 4 times a year. There's a January retreat. Usually that's based on a survey. There's one going out shortly to try to prioritize issues. Strategic board interprets those from the membership, and then we try to act those out. What is the SBS? I've had some discussion with people here about we need to stand up for patients. That's what we do. So the purpose of the society is to enhance the lives of its members and patients by promoting optimal vascular care, education, and research, while encouraging and supporting diversity, equity, and inclusion. Ron Dahlman, I don't know if he's here, I'm sure he is, but he did a great job promoting DEI within our society. And I pledge that Dr. Dalsing and I are still doing that. It's not because it looks good, it's because it's the right thing to do. We need to represent our patients better, and we need to represent all our members better. And I've always found that if you can get diverse input from multiple different viewpoints, you do better. So the membership is supposed to drive the priorities. The survey goes out in the fall. The strategic board of directors meets in January, and we look at these priorities, which I'll outline for you briefly. And then we try to decide how to act on that within the budget that we have. So these were the top 10 ranked strategic priorities from the 2021 member census. And I point out that the new census is coming out, the new member survey is coming out in November of this year. So please rank your priorities. But the top few have been pretty consistent over the last several years. For a while, branding was the top priority. That's still in 3rd place, but the top 2 are advocacy and public policy, and then quality and appropriateness of care and optimization of vascular care. And I think those things are still strong. Population health and DEI issues have recently risen up from lower in the standings, but do pay attention to your survey. So we have an MOU with each regional society. Each regional society is a little bit different. We do want input from you as what affects you, because what affects certain regions of the country differs. Dr. Dahlman helped establish the DEI Committee, which now is a fully functioning committee led by Vince Rowe, who's your current president. Branding campaign I was involved with, that did a good job initially. We need to keep keep pushing that because people don't know who vascular surgeons are and what we do. I think we're unappreciated. That, I assure you, will stay on the forefront of what we do. There's new sections both for young surgeons and women in vascular surgery. The young surgeons was actually spearheaded by Benita Chandra, who's a member of the Western Vascular. So the Western Vascular is active despite being only 19% of the SBS membership. What you do is important and it's valued. In no particular order, there's a lot of focus right now on advocacies, particularly related to payment cuts. So I think we're chronically underpaid for what we do. And I think looking at different models of reimbursement is going to be important going forward. The current hot topic is the reduction in reimbursement for OBLs. And I realize this is an important topic. There's a lot of attention being paid to it. It affects some members more than others. But I think it points out the fact that we probably shouldn't put all our economic eggs in one basket. So if you're going to have a diverse practice, you probably need to focus on multiple revenue streams and how to provide patient care in multiple venues and not on what currently is the most profitable means of doing that. And I'll leave it there. These issues are still important. So Medicare payment cuts or lack of increases has been a big issue and always will be. Workforce diversity and safety. So there's been a lot of work done on what we just discussed in the last paper. This is a hard thing that we do and it's tough. And no matter how good you are, you have bad days and your patients have bad days. And it's first time in my career that people have actually talked about that. I mean, that would never have been discussed when I was a trainee. And early in my career, it was just suck it up. And the people that led us acted as if there were no problems. There were lots of problems, and the people that led us and built our specialty were flawed but great people, but we need to acknowledge that and see how we can do better. I think recruitment and retention is really, really important, and how to figure out better how to deliver care. So one of the reasons I moved from Tucson to Houston was I wanted to see if I could do something in a bigger venue and also regionally. I think a lot of how we do regional healthcare and several of the talks today address that. The one from UC Davis about how to reach out to your community and how do we ensure that every patient gets access to the best vascular care, not just those who happen to make their way to your front door. I'm gonna skip over some of the time. So advocacy, there's a big group working on this. I don't think any of us can do this individually, but we need to hear about local issues that we may not be on the national radar. But I urge you, I'm not a big pusher for money. I have a hard time asking for money if you know me, but contribute to the SBS PAC. It's really important. There's no other society that's going to fight for vascular surgery to be fairly reimbursed and to avoid potentially at least reducible cuts than the SBS. So speak out and speak out with your checkbook to the extent that you're able to try to help the SBS PAC. The couple of things that have happened in the last few years that are much better. Amy Reed did a great job. So as secretary, she was also in charge of communications. A lot of you work on SBS Connect and we communicate with each other that way. I think that's a great forum because you can bring up vascular surgery specific issues and not hang your dirty laundry out in public like Med Twitter and Med Bikini. But it's a good forum and there's a lot of pretty good discussion that goes on in the SBS Connect. The SBS has tried to be more active in social media and they actually exceed now 10,000 followers on Twitter. If you haven't visited yet, this has taken years to put into place, but we have a huge infrastructure now. When I went to the SBS retreat in January in Chicago, I remember when it was Jack Cronenwet and Tom Riles and a handful of people. When we finally became one society, we hired Becky Marin, if you remember Becky. Now, when you walk through the SBS offices in Chicago, there's 40 or 50 people that work every day to do all the implementation of things that come from our members. And there's over 500 members that are on various committees for the SBS doing really good work. And that never happened before. That's extraordinary. So I'm here to kind of tell you that the SBS, I want you all to be SBS members. It doesn't mean you're not Western members, but we all got to be in this together. And the SBS is the only voice that really speaks for all vascular surgeons. I think the things that we've done recently that have been big improvements are the DEI work led by Vince Rowe and others, the branding work that I started and now Ben Pierce is working on, a lot of work on advocacy to try to get fair reimbursement. And the SBS has developed leadership programs, which have been really well received, as well as the wellness initiative that that Dr. Upchurch referred to in his address. Skip through that. So you're well represented on the board. It almost equally manifests the relationship of the number of vascular surgeons that are from the West. Your Western rep is Ahmed Abu Zamzan. Any one of you is free to talk to me. I'll talk to anybody offline about what I can do to help. And you're represented. We want this communication with I'm not here from the SVS to tell you what to do. It's a two-way street. I want to hear from you about what affects the region. Houston's kind of weird. I kind of think of it in the West. It's not really the West or the South, but I'm still an active member of this group. I thank you for your attention, your talent, your dedication. There will be time for questions, but be sure to go outside and enjoy this beautiful place that we're lucky enough to meet in. Thank you. Brief questions, or we can talk in the back later, whatever you want to do. Well, go see whales and play golf.
was looking for a break of life, but in the touch of heavenly light, and all the fires in my head said, oh, get a dream of a life again, and a vision in the sunny air, and all the fires in my head said, but all you need is one more touch. I'll taste of heavenly rush, and I'll believe it's so. And I need one more touch, another taste of divine rush, and I'll believe it's so.